There's a really good guy called Catch up later for you. Will, definitely.
Hopefully you'll be safe for a good one.
I went to Manchester Pride. So, I had a whale of a time. I was there with glitter and rainbow egg. He whistled.
I can't go to Manchester Pride, so I just might have to shoot over.
Oh, it's amazing.
It's very good. I think
Good morning and welcome to the HIV Prevention England Conference. It is so wonderful to see you all here today, gathered from all around the country, here with one goal in mind. Before we get started, there's some important things I need to say. There is no fire drill planned, but there are fire exits for those who might need them. They're either side of me and head backwards behind me if you are heading out, but obviously we are hoping that will not be happening. Importantly, please do not consume nuts in the building. The aircon is so good you might kill someone, so please don't make sure that happens. And if you do have dietary conditions, please do let our team know, and they will ensure that they are catered for throughout the event. So thank you for being here and gathering at the HIV Prevention England Conference. It's something that we as Terence Higgins Trust are proud to be part of, to lead and to share with the sector. It does such important work in ending new cases by 2030. So we have 5 years, 3 months and 24 days if we're to meet that goal of ending new cases by 2030. 5 years, 3 months and 24 days if we're going to be the first country in the world to meet that goal and end the onward transmission of HIV. 5 years, 3 months and 24 days if we're going to be the first time we've ended the onward transmission of any virus without a vaccine and without a cure. That's not long to go. We know there's a lot of work to do, and we have to have the determination to make it happen. We're looking for 4,500 people in England that are living with undiagnosed HIV. There's 14,000 diagnosed people with HIV who aren't taking their medication because of stigma, discrimination, racism, homophobia, transphobia, poverty, and much more besides. They must be high in our minds. And for those that are seeking out HIV prevention, it has never been more scarce. Condoms are at their lowest spend in the country's history. We have a 12-week wait on average to get PrEP if you're in a category that is, quote-unquote, eligible for that drug that could change people's lives. There is lots to do and determination in this room to do it. Impatience and pragmatism. I think that's how we feel as a sector. It's my approach running the Terence Higgins Trust, and I know for many of you it's the same. When we work in HIV, we have that passion for our cause and that drive for equity. But if we're honest, it's a little frustration too. Too often we meet people where their HIV acquisition could have been prevented. We know it, we see it. Too often we meet people where their diagnosis could have been earlier, and had somebody done their job properly, it could and would have been. We see people who could and should be getting their care, but the barriers we put in their place are what's holding them back, not them and their lives. And we want to take a very different approach to making that happen. Today is delivered by those people who've bottled up that frustration and turned up to those meetings, not with all the lists of things we can't do and why it's too difficult, but the people who say, let's try something new. Let's listen to service users. Let's try and try again. And I think that is what is so remarkable about the DNA of people who work in this sector, that determination to get it right and make a difference. Today has been made possible by an excellent team at HIV Prevention England and support from the wider team at Terence Higgins Trust. I want to single out Thomas, Nicola, Joe, Barry, Brogan, Taku, Caroline, Eugene and Dominic, all of which are people who work with real endeavour and skill to make not just today happen, but testing week and the year-long work that HIV Prevention England does. I also want to thank our HIV Prevention England activation partners who do amazing work and support that happening, all the speakers that you'll hear from today, and of course, importantly, our lovely sponsors at Gilead, Vive and Pasante. We couldn't do this without them. We are lucky in this field to have amazing civil servants, and not all virus and health advocacy groups can say that. But with Adam, Olivia and Bav, we are lucky to have allies on the other side of the table, fighting our corner when the doors are closed. I think you'll join me in thanking Professor Kevin Fenton for not only the work he does day in, day out in his day job, but the extra work he does leading the HIV action plan and making sure stuff happens. He is definition of swan-like. Whenever you see him, he is cool as a cucumber. Nothing is ruffling those feathers. But underneath, those legs, those legs are powerful, and they are making that power known. And behind those doors with ministers, we know he is not just persuasive, but encouraging of them to be bold and take more action. Finally, I want to pay tribute to those living with HIV. It is absolutely remarkable that in the prevention of the onward transmission of HIV, those living with HIV continue to take a lead, have the highest ambitions for our sector and the work that we are doing. If you look across the programme, there are people living with HIV on so many of the sessions, sharing not just their lived experience of HIV, but the work they do in this sector and that learnt experience to make sure their experience is not the experience of those who come after them. That, I think, is pretty amazing, and we are really in their debt. But if we're going to end new cases of HIV, it's really about leadership. We know we have all the tools possible. We could have done it yesterday, but if we're going to get it done by 2030, it's about convening all of the strands of work that we know are necessary to make that happen. And we have the determination to do it, but others have the power to make it happen. And the role of government has never been more important. As we get closer and closer to that goal of ending new cases, the role of those political leaders is important. And I want to thank the last government for the work that they did and the way they listened to us time and again on a series of issues, not least finding the funding not just once but twice for opt-out testing in our A&Es. We've seen how effective it's been in Brighton, London, Blackpool, Manchester, and now finally Salford. And we've seen how that has found people and re-engaged people and made a difference. Getting that extra funding to see it rolled out. And just this week, Birmingham started doing opt-out testing in their hospitals, and we know others are joining with it. We couldn't have done it without their leadership. But you'll know that the 14-year trial on whether you spend lowest amounts of money on prevention might lead to higher or worse outcomes has come to an end, and some things have changed. You will notice there's been a change in government. And we are lucky to have at the helm somebody who has spoken often about our cause in Keir Starmer. We have Wes Streeting as the Health Secretary, who has not just been a service user in our area and talked openly about some of these issues, but was a member of the HIV Commission himself and is probably more prepared on HIV than any other virus or healthcare issue. But we also have the most remarkable friend in the Public Health Minister. Andrew Gwynn has shadowed this role and its surrounding roles for a number of years, to great frustration, because it's never good having to have that shadow before your title in work. But he has been unleashed and is now the Public Health Minister. And we are really lucky to have a friend, somebody who's been consistently an advocate for our work, here with us today and speaking to you, but more importantly, leading this issue. Now, you have to promise me something. Do not let him leave this stage unless he promises a new HIV action plan and a way of sorting out the 1990 plan. Andrew Gwynn, over to you.
Thank you, Richard, for that kind introduction. Andrew Unleashed. You've been warned. And that's just for the civil servants. Look, I want to start by paying tribute to the fantastic campaigners in the audience. The Terence Higgins Trust, the National AIDS Trust, the Elton John AIDS Foundation, and so many others. Who went to Pride this summer? Put your hands up. Yeah, I went to Manchester Pride. I was invited by the brilliant George House Trust to march with them and their team and their float. And for me, I got giddy because I got to march with Russell T Davies as well to promote their undetectable equals untransmissible message. I have never felt prouder of my home city. I saw things that made my heart swell. Families and children, old people, young people, ordinary Mancunians supporting fellow Mancunians and having fun along the way. I saw other things as well, so ask me about that over a drink a bit later. But anyway, one of the perks of being a minister, dropping that shadow after 14 years, is decorating your office with the government art collection. And when I asked my team if there was anything there, and they showed me the catalogue, and it was all boring artwork. And then I was offered a portrait of a young man. The artist has sketched his bare chest and shoulders in deep red pencil. Your eyes travel upwards to the subtle details of his face. Two other figures, faintly sketched, either side, look straight at you, holding your gaze. These are the 3 Ages of Terry by Curtis Holder, perhaps the most famous sketch of the great Terence Higgins. And I love this portrait. Look, scrub what my script writers have said. Your eyes gaze up and you actually wander to 2 nipples. It's not the 3 Ages of Terry, it's the 2 nipples of Terry I'm gazing at. But it's not the original. The original is in the National Portrait Gallery, and MP's salaries certainly don't stretch that far. I didn't put it there to match my carpet. It was a lovely gift from Richard and the Terence Higgins Trust at our first meeting. The first meeting that I had with external stakeholders was with THT, the National AIDS Trust, and the Elton John AIDS Foundation, and I hope that reassures you of the priority I give to this area. But I love this portrait because of what it represents. No, not nipples. It reminds me about everything I want to achieve in government. No, not nipples. Look, for the avoidance of doubt, the new Public Health Minister certainly does not have a nipple fetish. Can we get that out there? Back at a time when AIDS was still called the gay-related immune deficiency, it was the THT, founded by Terry's friends, Martin Butler and Rupert Whittaker, who wanted to put a face to unseen suffering. The lives ended too soon. The families bent in grief. The communities ripped apart. These friends achieved that and more. They raised awareness of HIV, reducing the pervasive stigma around the disease. They raised millions of pounds for research. They put the UK on the path to ending HIV transmission once and for all. Curtis's portrait that hangs in my office reminds me every day whom I'm there to serve. The consequences of inaction, and what we can achieve when we work together. For me, it is a symbol of my long and proud history with the Trust. You have meant something to me my entire political career. As a councillor, an inspiration. In opposition, a friend. In government, a loyal partner. So now, as Minister for Public Health, with me and Wes at the helm, you will have no stronger allies in the vital work that you do. I want the bonds we forged before I was in government to become the bridge today that connects us to the communities we serve and helps us move forward together. I know you will do the hard work on the ground, holding me and the government to account when we fall short. Hopefully we won't. And pushing us to go further in our mission to end new transmissions in the UK by 2030. So from me and every member of the new Labour government, thank you. I also want to say thank you to the team behind HIV Prevention England. And in particular, I want to mention the brilliant Dom Edwards, who has worked on HIV Prevention England and its predecessors for 25 years. He's not just a director at THT, but a stalwart and a beacon for what people living with HIV can achieve. So Dom, a big thank you. Give him a round of applause. Now, as Richard said, after 14 years in opposition, I'm keen to make up for lost time. In the Labour manifesto, we committed to launching a new HIV action plan, and that is what we will deliver. We are working with you and with others to publish it by the summer of next year, and I have made it clear that it must follow some very clear and key principles. Firstly, the plan must ensure equal access and uptake of HIV prevention programmes, giving vital information to those who need it the most, and in making sure that everyone who should take PrEP, that game-changing drug, can access it free of charge on the National Health Service. Because, as I said at the start, the consequences of inaction are far too great. Secondly, we must scale up HIV testing in line with national guidelines. That means we must test, test, test. Now, I know the data, the figures, show that we're going above and beyond the UN's 95, 95, 95 target. And look, we should be proud of the progress that we've made. But I also know that data doesn't actually show the complete picture, because it doesn't always capture people who are not retained in care. And it's important that we don't rest on our laurels of that published data, which doesn't give the clear, true picture, because we don't and can't let anyone with a diagnosis slip through the cracks. So I have asked my officials to review how we measure those performance indicators, and I pledge to you this: later this year, we will publish new data that takes all of this into account, so we get the correct picture as we head towards HIV 2030. And look, credit where it's due. Those who remember me in opposition will know I don't always give credit to Conservative politicians, but I salute the last government for introducing opt-out testing in accident and emergency, because it's not a party political issue. We supported them in opposition as they moved this forward. And I've always worked with people on all sides of the political aisles to get stuff done. That one decision to expand opt-out testing has probably saved more than 1,000 lives in its first 2 years alone. And not to mention identifying thousands more cases of hepatitis B and hepatitis C by testing people, including heterosexuals and men who have sex with men who don't identify as gay or bisexual, who never even thought they were at risk. So our action plan will build on that success. Thirdly, we must improve the quality of life for people living with HIV and wipe out the stigma they still face. Just 2 years ago, Positive Voices found almost half of the HIV patients that they surveyed felt ashamed about their diagnosis, and 1 in 25 had been verbally harassed for being HIV positive. Let me be clear. It is now this government's position that one person getting verbally abused is one too many. That's why it's so important to smash the stigma in society for people who are HIV positive. Yes, we've come a long way since the 1980s, but let's be honest, there's still so much more that needs to be done in this area. Finally, and I think above all, I want a plan that reflects people. That means listening to people and understanding their needs. Every HIV patient, every person is a unique human being with their own wants, their own needs, and agency. And our plan must reflect that. That same survey by Positive Voices found almost 92% of patients were satisfied by their treatment plan. But we need to help the 8% who weren't satisfied. So I've been clear that to make this plan a success, we must tailor the system to suit every patient. In other words, we cannot pigeonhole patients into a system. The system should fit around the needs of the patient. And I want closer ties with civil society, supporting them to deliver this real change. Whether that's with the Terence Higgins Trust, the National AIDS Trust, the Elton John Foundation, or many partners across local government and every one of the organisations in our community advisory group. I want all of you to help us shape our action plan, because we each of us have our part to play. Public and private, business and voluntary organisations. Together we can turn the tide against prejudice and deliver lasting change, like those pioneering heroes of the 1980s. 2 weeks ago, I was proud to march alongside some of them at Manchester Pride. I thought about how much we all owe to those brave men and women, some of them still with us, others not, who started organisations like the Terence Higgins Trust. As they pass on the torch to a new generation, let's live up to their legacy. And I look forward to beginning this new chapter of our story together. Thank you very much.
He did good, no need for the heavies to keep him on stage and make those key announcements. Andrew, thank you very much, and it is an honour to have you here. And also, apparently this is your first conference and your first big speech as a minister, so we are really proud to have you here and to host you in that way. So thank you very much, and thank you for the work that you will do over the coming years for us. Next up, we've got somebody who doesn't need any introduction to this audience, but Professor Kevin Fenton is a friend, an advocate, and somebody who is fighting for us in public and behind the scenes to make this action plan happen. You'll know he's the Director of Public Health for London, but also he does many other things, including recently becoming the President of the British Association of Science. So congratulations on your new appointment. I hand over, and if you can greet in the normal way, lovely Professor Kevin Fenton.
Good morning, everyone. Good morning, everyone. Morning. Right, we need that energy. The minister has given us so much energy this morning, and I need you to keep that energy today. Because the work is hard, the work is long, but we are doing this work together. So colleagues, this morning I have the privilege of sharing with you my experience of supporting and leading and championing the HIV Action Plan. And I want to begin this morning by thanking the Terence Higgins Trust, our colleagues in HIV Prevention England, all of the partners who've worked with us over the past 2 to 3 years on the HIV Action Plan. And I'd like to thank you. Your advocacy, your voice, your persistence, your challenge makes a difference. Promise me you will never be silent in the face of injustice. And promise me you will not be silent as we move towards our ambition of ending HIV transmission by 2030. So this morning I wanted to do a little bit of reflection, and I was really pleased to see that the theme for the conference is focusing on health equity. Many of you know that whether in my work on HIV, my work on COVID-19, my work in London, health equity is a key part of what we do in public health and what defines our work in public health and what will define our work on ending HIV transmission by 2030. And I'm going to begin with a little bit of Public Health 101, if you'd indulge me, because language is important. Sometimes you hear colleagues say there are health disparities. And what do we mean by health disparities? Well, that simply means that there are differences. Differences, that's all it describes. Differences in the numbers of cases that you see between one group or another. The reason we talk about health equity is that we bring the principles of social justice to the differences which you observe. And that means that we're looking and talking about issues of fairness. We're understanding that everybody isn't starting at the same level in society, and therefore some people may need more help to get to that place of equality than others. It means that we have very different discussions on why these differences are occurring and therefore how we address them. And it means that when you look through the lens of equity, that everything you do must change, because when we know better, we do better. So, are you ready for me to start the lecture? What I wanted to do this morning is really just to take a short canter back on the journey over the last 3 years. And many of you will be familiar with this because you've been part of this journey as well. The bold announcement in 2019 that the government was committed to ending HIV transmission by 2030 set the pace and the tone that we needed to turbocharge our HIV prevention efforts. And following that commitment with a new HIV action plan has been a key part of ensuring coordination, ensuring new funding, ensuring new energy as we approach the declining trends of HIV in the United Kingdom and specifically in England. Now, bold targets are easy to say. What is much harder is to ensure that the funding follows the narrative, that the work gets done, and that as we're doing this work, we're having that laser-like focus on equity. And this has been a key part of how we've approached the work that we've been doing, because we are in a declining phase of HIV in the United Kingdom at this stage. And when epidemics decline, there are a number of things that you need to be aware of. Epidemiologically, it means that we're seeing lower and lower numbers of cases occurring, and oftentimes those cases become more and more geographically concentrated. So there are going to be more parts of the United Kingdom as we approach 2030 that won't be seeing any HIV cases because numbers are coming down. It also means that as the numbers begin to decline, the people who continue to become HIV infected or living with HIV are people who are more likely to be socially or economically marginalized or excluded. They're going to be people who have poor access to healthcare services and to preventive services. They may well be in geographic areas or settings or with risk behaviors which may place them at increased risk. And epidemiologically, the people who are much more likely to acquire HIV as we approach elimination are much more likely to have more complex lives as they look at the intersection of alcohol, drug use, mental health issues, high-risk behaviors. So the nature of the epidemic will change and as we approach the elimination of HIV transmission. So the key summary here is, as we approach 2030, the job will become more difficult because the epidemic is changing. Now, this will have huge implications for what we do as we approach 2030. It means that our programs are going to have to change. right? Because the nature of who's acquiring HIV is changing. And as the minister says, ensuring that the focus on equity, the focus on stigma, tackling discrimination, engaging communities, partnering with communities becomes even more important. And policy will need to change as well as we approach 2030. It means that we have to have very honest conversations about what's driving HIV transmission and who's getting infected. We're going to have very different conversations about stigma and discrimination and racism and poor access to services and marginalized communities and inclusion health. It means that the way we deliver services have to also change as well, because we need to now bring the community closer to us in statutory services in order to develop the services that our communities need. Again, with this slide, there's a lot that you can say in a picture, but what I wanted to drive home is the epidemic that we're dealing with today will change, and with it, we must also change our response. And that is why I'm so excited about the minister's announcement and the commitment to a new HIV action plan. Now, the current HIV action plan, as many of you know, had 4 key pillars, and I'm highlighting a number of them here. The first is around the equitable access of HIV prevention programs, and this must continue to be a key part of our work moving forward. You have seen the tremendous progress that we've made on PrEP access, on scaling up HIV testing, and continuing to work with our local authority colleagues to fund HIV prevention programs, even in some of the most challenging economic times. The Minister has already reflected on HIV testing efforts and the importance of scaling those efforts to ensure that we continue to reduce the undiagnosed fraction of people living with HIV within England at this time. We've been doing a lot of work over the past 3 years on optimizing access to treatment. And today we're having very different conversations about retention in care, maintaining people in high quality care, and innovating and looking at the importance of peer support workers embedded in HIV treatment centers as a key strategy of encouraging and engaging people in their HIV care. Phenomenal work that you are all doing to ensure that not only are we testing and linking to care, but keeping people in care as well. And we've also committed to improving the quality of life of people living with HIV, and that's been a core part of our work. And there's so much innovation happening across the country. In London, the work on an HIV charter, the work on thinking about HIV champions, speaking about stigma and encouraging and educating about HIV in the 21st century. So the HIV Action Plan has enabled us to focus, to deliver programs, to scale programs, and to drive forward. But the journey to 2025 and to 2030 will require us to build on this success and to ensure that we incorporate the learnings of the past few years. So in the next few slides, what I wanted to cover very briefly were some of the contextual issues that we need to be aware of as we think about 2030. First, that the patterns of the decline in HIV are not happening equally across the country, and we're likely to see significant changes between the pattern here in London and the patterns outside of London as well. Second, as we are going through the decline phase of HIV, keeping a close eye on new communities, new populations who might become living with HIV or might be affected by HIV transmission, and ensuring that we have data that enables us almost in not real time, but in a timely way to identify new and emerging populations will be key. We need to ensure that we are continuing to work on increasing access to care and ensuring that that time of linkage to care from diagnosis to receiving antiretroviral therapy continues to increase. And this has been a success story for us in England, and we will commit to continuing to do that. And finally, as you've heard from the Minister, we have phenomenal levels of viral suppression in England, and we will continue to look at our data, interrogate the validity and reliability of that data so that where we need to make corrections, we're able to do so. Understanding that viral suppression will vary by age, by gender, by where you are in the country, and so therefore our strategies to ensure viral suppression will be key. Now, context is going to matter as we move towards 2030, and here are some of the things that I know you have all been grappling with. In a post-pandemic world, when there are so many pressures that we're grappling with, how do we create the space to focus on HIV prevention and reproductive and sexual health and keep the momentum on what needs to be done? How do we ensure that in an environment of a cost of living crisis, rising inflation, that the funding that is required for scaling our prevention efforts exist and are used in the most effective way? How do we deal with populations that are more likely to be socially and economically disadvantaged as we move towards 2030? Do we have the programs for social care? Do we have the programs that integrate mental health care for people who are living with HIV? And finally, how do we ensure that in the context of changes in sexual health, we continue to have that focus on HIV prevention? And this last issue of the context of sexual health is critically important because we know that STIs facilitate the transmission of HIV. Now, the data are clear that what we're seeing across the country is a resurgence, especially of bacterial STIs. And this will require new ways of thinking about tackling those STIs, looking at new prevention technologies, but integrating our HIV prevention efforts as well. And this is particularly so for gay and bisexual men, where we do see a disproportionately high burden among some of the STIs. And therefore, how we begin to think about prevention efforts for HIV and STIs holistically will be critical. Finally, what I wanted to end on was just reflecting on keys to success as we approach 2030. And I think there are a few things in terms of emerging best and promising practice from the first 3 years of the HIV Action Plan that we will certainly be bringing towards our work moving forward. First is the importance of strong leadership and cross-sector collaboration and coordination for the HIV response. Across the country, there's so many fantastic examples of where coordination is taking place, whether at the national level through the HIV Action Plan Implementation Steering Group, whether it is in localities across the country with the Fast Track Cities program, or whether it is commissioners coming together to think more holistically about commissioning for services. It is crucial that for the new HIV Action Plan that we embed coordination and cross-working between the NHS, local government, communities, and others for success. We know this is necessary, and we know it works, and it would be important for us to embed this. Second, new technologies are going to be critical in our journey towards ending HIV, and we need to ensure that we are realigning our investments and investing in and spending in the right places to have the impact. And we have seen some of the amazing work that we've been doing on reprioritizing spending and the impact that that has had. This example is of the HIV and bloodborne virus uptake testing program, which, as you've heard from the Minister, has been critical in uncovering undiagnosed HIV infections. The early data are presented here, but you will see throughout the course of the conference today other presentations on more recent data on just how powerful this intervention has been. But this is just one example of new approaches to testing and linkage to care. And a key part of the discipline of the next 5 years will be looking at new approaches. Third, we must prioritize prevention and promotion of health, and we must think about this in a holistic way because the issues of health equity are critical. And again, they've been great examples by work you're doing in places across the country of where we're looking at health promotion and applying a much more equitable lens. In London, we have our HIV prevention program and our Do It London HIV campaign. Around the country, you are using resources in innovative ways to continue to speak about HIV. And this is going to be critical, that cultural competence of our prevention efforts as a key part of what we do. Finally, and most importantly, as we move towards 2030, we must deepen the work that we're doing on community-centered approaches, on cultural competence, and really looking at asset-based approaches to preventing HIV. And that will be certainly a commitment from myself as we develop the HIV Action Plan, that the voices, the experience, and the wisdom of communities are integrated into that work. So whether it is the work on the Fast Track Cities program, or again, other examples from across the country, bringing communities in to be a part of co-producing solutions will be a critical part of what we need to do. So colleagues, thank you for your work. Thank you for your passion, and thank you for being with us and helping us on this journey towards 2030. I hope that in the presentation that you've seen today, you too understand that what has gotten us to this place today will not necessarily be what will get us to 2030. We will need new approaches. We will need to bring communities closer to us. We will need to have open and honest conversations about equity, about discrimination, about marginalization, sometimes difficult conversations for us to have. But we are a part of the HIV community, and we are used to having difficult conversations. That's what got us here. Thank you.
That was remarkable and excellent, Kevin. Thank you so much. And we can see why we've been making the progress we have under your leadership of the action plan, and long may that continue. So next, I'm going to introduce Memory. And Memory, you'll know, is a HIV advocate, but crucially, the coordinator of UK CAB's advisory board. She speaks with passion and determination about not just HIV and her experiences, but others, and particularly the experience of women living with HIV. And we're so pleased to have Memory Sashikoni with us today. Over to you.
Good morning, everybody. I'm very nervous. Okay, so I'm here. 22 years ago, I was diagnosed with HIV with a CD4 of about 6. I was visiting the UK on a family wedding. My aunt was getting married. Back home, I was the manager of, I was an IT manager for a regional NGO that dealt with the development issues in Southern Africa. So the UK was not my first visit. I have a large family here, so I'd been coming to the UK for a lot before that. So this visit was just one of those visitors. Christmas, my aunt was getting married on the 21st of December. So I left my car parked at work. My son was going to mid-year secondary school. He was 15. I left my brother to sort out his school fees for January because I was going to go back after the schools had closed. So after the celebrations of the wedding, Christmas, I didn't feel well. And my aunt recommended that I do get a test, just an HIV test, to get that out of the way. So straight after New Year, I went to a local GAM clinic, had the test, didn't think much about it. You had to go back the following day to go and get your result. 24 hours later, I went back, and everything just fell apart, being told I was HIV positive. It is, up to this day, a blur of what I was told after that. Luckily enough, I had 2 people with me, and I was just told to wait in reception while they wrote a letter to go to the nearest hospital, which is the North Middlesex Hospital, where I'm a patient now. So getting to the hospital, I had no idea how to navigate the health system. I didn't know anything about HIV. I didn't know about AIDS, not HIV, just because I'd lost 5 family members, my uncle, his wife, and 3 cousins in the space of 1 year. So I was aware. We're losing work colleagues that were at work as well. Somebody doesn't come to work for a week, next thing you're going to bury them. So it was very tough in Zimbabwe, and there was no treatment. Having done that, I was referred to go to a support group, a peer support group at Positively Women, which is now Positively UK. So walking in there and seeing all these women being jovial and just laughing and chatting, and thinking, do they have what I have? But anyway, I met a very lovely support worker, a caseworker, who was looking so glamorous, telling me that she has lived with HIV for 17 years. I looked at her and felt, and that's when I thought, okay, I need to do this, I can do this, I need to live. I jumped into volunteering and became part of the editorial team of the magazine that was going to women nationally. Within 3 months, I was so empowered and had gained some self-esteem. I put myself on the cover of that magazine, just telling my story about asylum seekers. Of course, in the background, there's immigration coming. I was here on a 6-month visitor's visa. So with the support from the organization, I managed to get a lawyer. Those days, they were quite available, and it was a lawyer who was doing it for free, and for a freelance, not freelance, but for free. So she did work very hard, and 6.5 years later, I got my stay as a refugee, which means I still couldn't go home. So my son was there at home, going to see him, but just talking to him. My family did support to get him through school. And the first job that came about was the UK kept position at HIV iBase. I applied for that job. I had no knowledge of treatment. You go to the hospital, having to understand what medication you are being given or what's being said was, of course, Greek to me. I managed to learn from not identifying pills as the orange one and the blue one to the actual names. I was determined as well to speak out and make sure that other people like me, who are women or whoever they are, do not go through that phase of being hidden and not showing that you can actually live well with HIV. So, of course, I was, from my diagnosis of CD4, I had a lot of opportunistic infections. So first, I was told that I had a kidney disease, which I didn't know I had, but then it does run in my father's side of the family. So that went quiet for a while because I was just going through other problems. I was lucky enough to get a transplant in 2015 from a cousin, and I'm here today thriving. However, in February this year, cancer had to come by, so I was diagnosed with breast cancer in February this year. It was an early diagnosis, all it's managed well, done my radiotherapy, I'm well. So throughout this whole difficult journey, there's something called support. You find people that you get on with. There are organizations that give you support. And having been to so many support groups, I was coordinating another support group in Enfield where I live for Black African and Caribbean people. But you get kind of worn out by the basic support group. It's still helpful for other people. So there were 4 other women who became close friends. And then we started our own journey, like just having a support group of 5 40-something-year-old women. We are now in our 50s. And we just thought, what do we do with all this knowledge and expertise and experiences we have had? So when it came to the 40th anniversary of the discovery of the AIDS virus, we decided to write a book. There's 5 of us, the co-authors, who are named Angelina Namiba, Winnie Seruma, Rebecca Mbewe, and Charity Miranda. So we sat down and thought, we need 40 stories to get people to understand how us as the Black community have contributed to the HIV movement in the UK. So we got our allies, who are our doctors. We have Professor Kevin Fenton, who also contributed to the book. And a lot of other people did contribute. And the book is now out. It's called Our Stories Told by Us. and it's available on Amazon. With the UK CAB, it's an organization that is an activist organization for treatment. It has that unique thing about just focusing on treatment. We do work with all the other HIV organizations, and we look at people as individuals. So it's the voice of the community in terms of being representatives in clinical trials, in clinical sharing, we have representation with the British HIV Association, BIVA. I'm a representative on several studies, and the main one that I'm still on is now the POPI study on aging, HIV and aging. We meet with the pharma to kind of understand what they are doing, question them on their new drugs, and just stay up to date with the latest progress in treatment. Looking at women, I mean, I'm a woman, so I have to advocate for women. I was reviewing the key findings of a study that was done in 2018 with Sophia Forum. There's a publication online. It's called Women and HIV, Invisible No Longer. This was 2018. And looking at the inequalities then, which are still not addressed today, which is a bit worrying. I will not go through the inequalities, but I'll just talk about, what can we do as we approach 2030 in the few years that we have left to try and make sure that we are all on the same page. Of course, we still need universal access to consistent HIV treatment for everyone globally. We still need our peer support. With the new opt-out system in A&E, every time I come across somebody who's telling their story or who has just been newly diagnosed, I'm still very touched. Everybody has a story to tell. And without that peer support, some people cannot get through just accepting that they have HIV and therefore being able to stay in treatment and take their medication correctly so that they do not pass on the virus. Stigma is still a big thing. Wherever you go, there's stigma. But stigma does kill. People disengage from care, which is another big problem within the HIV community, or because they can't be identified in their community, in their church, or by their family that they are taking HIV medication. Yet the risks of not taking HIV medication are far greater than the stigma for me. What can they do to me if they know I'm taking HIV medication? At least I'm in control of my health. And I know that I'll not be able to pass the virus to anyone else. We also need the tailored support services. We are aging. I'm 58 with multiple morbidities. I say to people that every body part of mine is a consultant, and that's not a lie. How do I link up all those appointments, consultant? I have to take a letter every time with a list of medications that I take, with all the diagnoses that I've had and all the treatments that I'm going through to just make somebody else understand. Can I just have one thing where somebody puts my NHS number and all this information comes up? So, of course, the theme of this conference is prevention of new infections. Women still struggle to access PrEP, and the biggest highlight of the AIDS conference in Munich this year was lenacapavir. When are we going to get it? It works. It has shown that it works in not acquiring new HIV transmission. It's there, but it's not accessible. So what are we going to do in the UK, in England, and globally to end these new infections? We still struggle, and we need to focus on the vulnerable communities like trans women, women who are in very difficult abusive relationships, and women in conflict zones. We want to be involved in decisions that are being made for us. These are the Denver principles from way back. We want to be we want to be literate. The UK CAB does a lot of activist training where we can understand research, being able to see that if they say 75% of this cream reduces your wrinkles, okay, it was only on 73 people. How does that work? So we need to have that literacy to understand when research is being done, a new drug is developed, only to find that there were 6 women in the trial. We are women. We have different, our biology is different to men. We are taking the same drugs that have only been tested on men and very few women. We are menopausal. My bones are weak. Everything else on me is changing. How can I still be not be able to know that I'm taking this drug, it's not going to have long-term effect on my bones or just my mental well-being. Mental health services are still a big issue. As we age, of course, I mean, I have brain fog a lot. I meet people and I'm like, oh, hi, but I can't remember their name. I still smile. The minister did talk about focus on quality of life. I think that's very important. We all need to live well, not just, we are something else beyond being undetectable. Yes, I'm undetectable, but I also need a good quality of life. I need to be able to access services when I need them. I need to be able to access physiotherapy, for example, if my shoulder hurts because I'm developing arthritis. And so I think there's quite important things there. We also need to focus on equity. These efforts to end AIDS in 2030, in the 5 years and 3 months that we have left, are a priority. And we need everybody to be involved so we can all have the same access to good health, we all need access to good health and equal opportunities in our treatments. We still need investment in ensuring that services continue to run to support people living with HIV. I said earlier, I'm getting to be an old woman, and aging with HIV has its own problems. We have too many conditions, and we're starting to think of care homes. Is our health system robust enough to accommodate our new needs as we age? We are the first generation to be aging with HIV, and I leave that question to the minister. Thank you.
When Memory's speaking, always prepared to be upstage. Isn't she amazing? What a fabulous advocate for our cause and for people living with HIV and women living with HIV. We've had amazing speakers to start our day, and I hope you enjoy the rest of the conference today going forward. There's a number of sessions throughout the day, and I would like to point out to you that Gilead, our very generous key sponsors, have Kevin Fenton on the panel as well as other people. So if you wish to see Kevin's great persuasive skills again, you've got another session that you can seek out during the conference. And we've got a little break now, so you've got till 10:50 for the next session. And if you go through, there is, you'll see around that people in the HPE T-shirts will direct you in the right way. There is a quiet room available for people, there is a prayer room for people, there is poster displays throughout the conference, and there are different toilets, including gender-neutral toilets, if people prefer to use them. I hope you've really enjoyed this first session. Please join me again in thanking Memory, Kevin, and Andrew Gwynn for being here today and starting us off.
I don't
more if you're on the lectern as well.
No problem, we're going to go down that
Okay,
see all these little
perfect.
spots? I'm going to sort it for you, don't worry about it.
Perfect. Yeah. Awesome. Cheers. Yeah, if we could just do
That's right. And before it.
Yeah, perfect. Yeah.
Sorry, I forgot to check that because I realised this when I played that next.
I'll do that. No, that's
Yeah, no, fair.
Put it all in one
But
spot.
because just like we will have the minister, we will have Kevin who is the leader, so we do it in here.
Yes.
Yes, makes sense. Makes sense. Let me just go up to the lectern and see.
That's better already.
How was the panel? Were they okay? I'm trying to light them up a little bit more. Don't forget them, yeah?
Again.
I need a bit more here. You need some on this way. So the one on the end, or just turn it to the right side. That'll have it.
We're basically dark, Kevin, so we changed the lighting a bit.
He's a bit taller than everybody else.
No.
Are you good with that?
I'm good.
I've done the church as well for you.
Perfect. Cheers. Perfect.
everyone. I think it's probably a good idea to get going because it's nice to chat at the end. My name's Catherine Dodds. I work at the University of Bristol. I've been working in the HIV sector since before Kevin Fenton's chart started, so it was very interesting to kind of think about the different places that I've been in along that journey, and perhaps many of you did as well. So I work as an academic. I'm a social scientist, brought up in kind of the traditions of sociology and social policy, and I'm also an HIV activist, and I think that for me is a really important part of what brings me into this work. I don't see those as separate boxes. So in terms of our session today, we're talking about insights into PrEP awareness and needs. We've got 3 tremendous speakers who we're going to welcome, and I will introduce them in turn. We will please save questions and discussions until the end. And for each of the speakers, I will be maybe sitting down there to flag you about time. So I will give you a warning that you've got 5 minutes left and 1 minute left. If that's okay with you. So to start off with, we've got Mike Downey from Renaissance UK, which is based in Blackpool. And Mike is the PrEP project worker there. He's been working there for a year, having been a volunteer before that time at the University of Central Lancashire, studying sexual health. So Mike's presentation forms part of the Be Prepped project, which began in May 2022. So I will leave it with you, Mike.
Hello. You'll have to, if you don't understand anything I say, it's because of the accent. We're just going to put it down to that. Cool. As Catherine said, my name is Mike. I've worked for Renaissance for the past year, and I've been taking over the Be Prepped project from my colleague Patrick, who you might have seen before, I'm not sure. The project ran for 2 years in Lancashire, from May 2022 to May 2024, and for 6 months in Blackburn with Darwin as a pilot project, from October 23 to March 24 just passed. The aim of the project was to increase awareness of and access to PrEP for those in rural and marginalised communities across Lancashire. I don't know if any of you have been to Lancashire, but the villages and cities are few and far between, and a lot of people are in the back end of nowhere. So the point of the project was to try and get the message of PrEP to those people. The original plan was to create a brand that would be visible across the whole county. So we got started on some designs. We first of all had a service user consultation. I won't bore you with the very long and in-depth charts about which colour they preferred, but we ran a service consultation on different colours, different designs, and fonts and things like that, and these ones were the ones that came out on top. However, we did have to be very careful. Due to the MHRA guidelines on the advertising of medications, also called the Blue Guide, disease awareness campaigns aren't allowed to advertise specific medications. So we decided to take the pills out because I'm not about to be dragged in front of a judge. So these were the ones that were kind of remade after we made that decision. These were then taken to a designer who professionally made them a bit brighter, made them a bit more, zhuzhy, and we ended up with these, which I think are fabulous. And we wanted those branding messages to be everywhere, so we decided we wanted to put them in GP surgeries, posters, leaflets in different healthcare settings across the county. We wanted to take over the sides of bus stops and have our message driving down every street in Lancashire, and of course to take social media by storm, as is so easy to do these days. But during our planning phase, we costed out just how much it would be, and it would have cost a lot of money. And leaflets get replaced, leaflets get torn, posters get put down, and the next best thing comes up. The next best movie takes over the sides of buses and bus stops, and social media is of course a beast that can never be tamed. So yeah, we did cost it up. It would have cost a hell of a lot of money that we just didn't have. So we had to come up with a different plan. We did really like the idea of the bus though. And we couldn't quite get that idea out of our heads. And then one day, someone put forward the idea of buying our own bus, which, it's a bit crazy, isn't it? But we did. We did actually buy a bus. We bought a bus. We then drove an 8-hour return journey to Scotland to get that bus. We got the inside of the bus completely refurbed. We got the outside of the bus branded and shouted our message as loud as we possibly could. We found somewhere to park the bus, surprisingly more difficult than you'd think, and then wrote the longest risk assessment I have ever seen about that bus. But at the end, it was worth it because we got our lovely Patricia, the little sexy bus. Is she going to pop up? Is that going to work? There we go. This is Patricia. She is my baby. I'm very, very close to her and very affectionate. And she was fully kitted out. She has heating, she's got aircon, running water, electricity, anything you can need. And we took her all over the county, from Burnley to Burscough, from Lancaster to Leyland and everywhere in between. And she could be seen driving down the streets of Lancashire, whether it was rain, sun, or even snow, even though she did take an hour to defrost. But yeah, we really enjoyed taking her all across the county. You could see her at a public sex environment in Lancashire. You could see her at an event, or even just parked in a car park in her capacity as a moving billboard. It's always funny to think we have photos of Patricia sitting below billboards we were originally planning on putting the message on, and then we can just drive her away and don't have to pay them anything, which is lovely. In public sex environments, we were able to use Patricia to provide instant HIV testing to the men who were using those sites, which we found incredibly useful for targeting the heterosexual identifying MSM community. That community, as we know, is incredibly hard to engage in services. So taking the clinic to them with the promise of anonymity and not having to find time out of their schedule to go to a clinic, and it was something that really allowed them to engage with services a lot easier and a lot more discreetly. We also worked very closely with Brooke in Blackburn with Darwin, and we got home testing kits on board Patricia as well. So when we went to the cruising sites in Blackburn with Darwin, we were able to give a full screen to these people for chlamydia, gonorrhea, HIV and syphilis, which was very useful, especially at some of the more popular cruising sites in Lancashire, which are within Blackburn with Darwin's boundaries. Now, on a really good week, I could maybe talk to about 100 people about PrEP. If I had a few events booked in, had really good engagement at those events, 100 people, that's a pretty ballpark average. But in order to get our message out even further, we developed a training program. So instead of talking to 100 people in a week, I could train 12 professionals across that time. And across the project, we trained 228 individuals from over 27 different organisations. And as part of the post-questionnaire survey that we did with them, we asked them how many people they would come into contact with in an average week. The average across all of those people was 34 people. So even if those professionals only talked to a quarter of their clients, that's still 1,938 people. And that we found to be much more impactful, especially because these people were working across organisations all over the health and social care spectrum. We had people working in drug and alcohol work, we had social workers, we had people working for local authorities. And these people are going to interact with people that I never will, that are never going to engage with me. But the message of PrEP can still get to them. The training was incredibly successful, and we've now developed that into an online training course, which is available for free for anyone who wants to take it on the BPrep website at bprep.co.uk. We also made a podcast because we thought that the lived experience was something that we were kind of missing from the project. So we developed a podcast where my colleague Patrick spoke to people who are living with HIV, people who work in the HIV sector, as well as those who were members of the original PrEP trials all across the country, including the IMPACT trial. And it was made to increase awareness of HIV and PrEP to the general public by letting those people hear lived experience, and is available on Spotify if anyone wants to have a listen. Now, during the course of the project, we had 3 main challenges. Now, this project focused on PrEP, pretty obvious from the branding and the name and just everything, pretty obvious. But very quickly we realised that you can't talk about PrEP until you talk about HIV, and you can't talk about HIV until you talk about sexual health. So the remit of the project expanded much wider than we thought it was going to at the beginning. Now, that's not an issue for me because, as you can already tell, I love talking. So we got over that one very quickly. And I talked to a hell of a lot of people over the project. But another challenge then pops up because, and nothing can be easy. Because of the nature of the conversations that we had, there was absolutely no follow-up. We never seen these people again. We didn't know if they took our advice and went to a clinic. for most of them, I don't even know their bloody names. And that's information we will never know. That's just the nature of the beast. And kind of the issue of that was, if you don't know how many people are doing something, you can't report your KPIs. And in the charity sector, reporting your KPIs is incredibly important because that's where you get your money from. And we didn't have any KPIs to report. We didn't know how many people attended a clinic. We didn't know how many people took our advice. We don't know how many people literally said, oh, I can't be arsed, and walked away. That's information we'll never know. However, that takes us on to our highlights. Our commissioners were incredibly, incredibly generous to us. They didn't give us a single KPI. We, of course, reported how many people we talked to and the events that we went to, but they didn't ask us for a single number. They didn't ask us how many people had gone to clinic. They didn't ask us how many people were like, oh, that's great. They didn't ask. And that allowed the project to grow so naturally, to become more than we ever envisioned it would be at the start. For example, we partnered with clinical services in Lancashire to provide full screening and PrEP prescriptions on the back of the bus at Pride events across Lancashire. We've attended 5 of those events with clinical services, and across those 5 events, we have tested 45 people with full screens, venous bloods, everything, hepatitis, all of it. We also prescribed 19 people with PrEP at a Pride event on the back of a bus. And those people, you never know. That PrEP they got that day might have prevented an infection that night. And that's something that we are incredibly proud of. Furthermore as well, the kind of main highlight of this project for me was that we were able to engage with communities that we found it very difficult to engage with before, especially the heterosexual identifying, many of sex with men community, and also the communities that don't access services as much as others. For example, those who are in minority ethnic groups, those who are trans individuals, and this bus created a way for them to engage with services that was more accessible to them. And finally, she did achieve her #1 goal. Patricia did deliver the message of PrEP to the rural communities across Lancashire. And I don't think there's a part of Lancashire that we didn't cover across the 2 years. And I must say, some of the views during our drives were pretty stunning, although she is terrifying to drive. But some of the views were stunning, and that's coming from a city boy. So I think she's converted me. Now, I did say that during the course of the project, we found it incredibly difficult to measure impact. But I do want to leave you with some figures. So in the 2 years prior to the project, Lancashire Sexual Health Services have told us that they had 839 appointments for PrEP. In the 2 years since that project began, they've had 1,561 appointments for PrEP, which is an increase of 86.05%. Within Blackburn with Darwin, they told us that 38 new individuals had started PrEP in the 6 months during the project when it ran in that area. We don't have full figures, but we can estimate from PHE data that that is roughly a 65% increase. And we're still waiting for full figures to compare this to the England average, but in England as a whole, the number of people the increase in PrEP appointments from 2021 to 2022 was 40%. So I think we can safely say that the project did have an impact, and more people are aware of and accessing PrEP because of it. The funding for this project has now ended. It's done. But Renaissance will continue to promote the message of PrEP as a vital part of reaching our 2030 goal, as an incredible tool for people to take control of their own sexual health. We'll simply be doing it under a new name. The name of our new HIV and sexual health service, which is launching later this year to pull all of our commissioned contracts into one. And that name is Revolution. That will be our new HIV service that is launching later this year. More to come on that. And Patricia will be getting some new clothes. So she's very excited. So look out for that. That is everything from me. I'm happy to answer any questions later on. But thank you.
Beautiful. Love it when a speaker ends just before time. So lovely and very exciting news about Patricia. Next, exciting news about Phil Samba. So Phil is a social activist, a researcher and writer. He's a project coordinator for the Partnership for Black People's Health at the Love Tank. If you've not heard of the Love Tank, where have you been? This is a not-for-profit community interest This not-for-profit community interest community promotes the health and well-being of underserved communities through education, community building, research, events, communication and design. So it's my pleasure to welcome Phil. He's going to be talking about what are the PrEP and sexual health needs of young queer men for 15 minutes.
It's always an issue at conferences. Hi, so what are the PrEP and sexual health needs and experiences of young queer men in London? So I'm going to present on a report that we did from this. Research paper that was community research that was developed, designed, and written by Dr. Benjamin Weil. I conducted some of the research and alongside Ben and Asad Zafar, who's in the audience. So I want to talk about like kind of what we did, how we did it, and kind of what worked, what came out of it. Okay, starting with rationale. What is data about young queer men suggesting? So indicators suggest that young GBMSM aged 18 to 25 are a subpopulation with particular needs and experiences of sexual health. 22 data from UK Health Security Agency suggested that young GBMSM have the highest diagnosis of the most common STIs, chlamydia, gonorrhea, and syphilis. Data also suggests that young GBMSM have a different relationship to PrEP compared to older men. Reports from the PrEP impact trial show that young GBMSM were less likely than other men to take PrEP, an observation that has been flagged by researchers and clinicians of particular concern. The uptake of PrEP. The slow uptake of PrEP amongst young GBMSM is possibly because this group has a different relationship with HIV compared to other generations. Many young GBMSM made their sexual debut since the PrEP became available on the NHS and became an established and important tool for HIV prevention, as well as U cause U. These advances have made measurable differences to sexual health and HIV, with newly or recently sexually active GBMSM coming of age, and the shifting relationships to the HIV epidemic may or not account for some of their sexual health decision-making. So there's also a need for a greater understanding of this group's relationship to sexual health and their sexual health services, in particular PrEP provision. Not only is such an understanding integral to better defining the needs of young GBMSM, needs that are only roughly sketched out by numerical data, is a vital way of ensuring that resources and programs of work developed to meet the needs are tailored to the experiences of the people that they intend to serve. So how did we do this? So we did this through focus groups with 18 young GBMSM in October and November of last year. The report came out this February. And it consisted of 13 PrEP users and 5 non-PrEP users, 3 of whom had never used PrEP before. Two of them had used PrEP before but discontinued, and they were ethnically diverse. The majority of them, 10 out of the 18 actually, came from non-white or mixed backgrounds. Eligibility. To be eligible for the study, the men had to be GBMSM, which also included trans men and non-binary people who have sex with GBMSM. They had to be aged between 18 and 25 and living in London. To ensure a broad range of perspectives, the focus groups were conducted with a mix of both PrEP users and non-PrEP users that were people that were not currently taking PrEP but were eligible for it. Engaging non-PrEP users was actually more challenging as there's an underestimation of the barriers that are even in place for them. We suspect that people may not even know our work or even trust sexual health services. We're aware that some of the people that face some of the most difficult barriers might not even have taken part. So through recruitment, the men recruited were through mailing lists known to the Love Tank, broadcasts on Grindr, the Hookup app, and social media posts on X, formerly known as Twitter, and Instagram. For the structure, for half of the focus the groups, participants were asked about their experiences and their relationships with sexual health services and information, their relationships to HIV and sexual health overall, and their experiences of PrEP. The second half focused on a related study, which was evaluating and essentially stress testing the acceptability for a potential model of providing PrEP outside of sexual health services. The stress testing has led to a recent online PrEP pilot in East Sussex, and we're now looking into exploring other ways to provide PrEP outside of sexual health clinics. So the findings were broken down into 3 parts: the relationships to HIV and PrEP, barriers to PrEP uptake, and experiences and perceptions of sexual health services. So I'm going to talk about some of them now. Acceptability acceptability of PrEP. All participants considered PrEP a highly acceptable and valued tool for HIV prevention, even non-PrEP users, including people who had never used PrEP at all before, regarding it as something that was favorable and expressed mild concerns about using it. PrEP users were flexible about how they took it, some doing it dailying, some doing it event-based. With the PrEP and HIV anxieties, the men that used PrEP universally expressed that taking it helped eliminate their anxieties about getting HIV. They felt that this enabled them to have sex without worrying, to feel more satisfaction, and also allowed them to feel like more carefree, to have more partners and have more spontaneity when it came to sex. These men said that they felt like their diminished HIV anxiety was in part a product of their age. Some of the youngest men in the groups noted that why they felt it was important to understand the history in HIV and AIDS. They spoke of the AIDS crisis as an episode of the past. They were more worried about STIs than HIV. Not all participants felt the same way about acquiring HIV, though. A small number of the men noted that although they used PrEP and consistently considered U equals U, they still felt anxious about the possibility of seroconversion. Explaining their anxieties, these participants cited the knowledge that HIV was a lifelong, although treatable, condition, and also shared experiences of growing up in households or cultures where there was a significant taboo or stigma around HIV and homosexuality. Barriers to PrEP. So speaking about the experiences of and relationships to PrEP, PrEP users and non-users described several potential barriers that they may explain for why they or their peers might not be using PrEP. Starting with stigma about PrEP, a number of the men highlighted stigma about PrEP that might affect people's decision to use it. They noted that among GBMSM there could be a whispered moralizing about PrEP, how PrEP could be considered something that like a promiscuity pill, or it could be something for people that have too much sex or lots of sex. Others noted that PrEP was sometimes regarded as a pill for gay men, and they suggested that this framing could dissuade people from accessing PrEP, especially those who might not be out about their sexuality or be connected with gay men. Access difficulties. Across the focus groups, individuals who had never used PrEP before regarded it favorably and expressed a desire to initiate it. These participants identified a single factor as the foremost barrier to their accessing PrEP. The sexual health services and their infrastructures were excessively complicated to navigate. All of the participants, all of whom were migrants, suggested that these systems were especially difficult to navigate for recent arrivals in the UK, particularly without the support or guidance from someone who's more fluent on how the services work. A non-PrEP user said, "I haven't been to a clinic before. I moved here 2 years ago. It's unnecessarily complicated, and especially for immigrants." Perceptions on the impact of the body. Although PrEP was an acceptable and highly valued by all participants, a few of the men gestured to concerns that they or their peers held or had held about the impact of PrEP on the body. People who had never taken PrEP, for example, all suggested that they had some concerns about the potential for side effects when taking PrEP. Although none suggested these concerns were sufficient enough to stop them from using it, others noted that they had friends who were increasingly suspicious of inorganic interventions such as medications and vaccines. And they feared that PrEP might be an adverse impact on their organs. 2 PrEP users did suggest that they were worried about taking PrEP on a daily basis and how it would affect their health. One said, PrEP user said, "I started taking event-based maybe 3 years ago. And then once I started sleeping with more and more men, people for work, I was then like, no, this makes sense for me to take it every single day. But I was scared about what it could do to my liver." going into the experiences and the perceptions of sexual health, sexual services. There was coming under the confidence of sexual health services, participants expressed confidence in the utility of services provided by clinics, noting especially that they tended to trust clinic staff to instruct them on which vaccines to take. Many of the men noted that clinics were key to their early education about STI and HIV prevention methods. However, they also explained that they only received this information upon their first visit to a clinic as a young person. Typically following a sexual encounter that left them anxious about exposure to HIV, they noted in this way that clinics were an ad hoc replacement for early and inclusive sex ed. They also praised clinics that they deemed queer-friendly. Participants tended to value non-judgmental encounters with practitioners and, where possible, forming welcome and friendly relationships with the staff of the clinics that they frequented. Service access issues and impact. The men described difficulties accessing appointments at clinics. They complained about the scarcity of appointments, whether for PrEP, STI treatment, or testing at their chosen clinic. Available appointments were often at times that were impossible to attend, for example, like during the day. And for walk-in clinics with no options of advanced booking, participants complained about the excessively long waiting times, which made it impossible for them to attend. And several of the men shared a similar experience of queuing for appointments in the early morning, only to be turned away. Some individuals felt that these failures of service access had worsened since COVID had started, noting there hadn't been a reversion of cumbersome systems adopted in response to the pandemic. A PrEP user said this: "In London especially, it's like gold dust trying to get these appointments." Gaming the system. Some participants shared methods of gaming the system in order to get an appointment by saying that they had an STI when they didn't, or by searching for appointments across several different London clinics, with one of them saying that he had to look across 4 or 5 different clinics before he could even make a booking. Participants noted that moving clinics routinely made keeping track of, on top of vaccine protocols, difficult because necessary records were not shared between clinics. The men reported that young people, especially those moving into London, not just making their sexual debut, may find navigating sexual health services for the first time particularly confusing. Views on online testing. For many participants, online Sexual Health London self-testing kits were a much valued alternative to clinical appointments. Some of the men described a pattern of alternating between receiving tests in the clinic, being tested in the clinic, and testing at home. But not everyone valued online testing. In addition to the loss of what they valued about clinics, some participants commented that they found self-testing difficult and even unpleasant to do, particularly when it came to drawing blood. Lastly, negative experiences of clinic care and organization. A handful of the participants described having a significant negative experiences in clinics that impacted them in various ways. One participant had an encounter with a doctor who he felt was judgmental about his sexual behavior. He described because of his experience, he considered not returning to the clinic at all. However, he was convinced to try again by the quality of care he received from another member of staff. So, discussion. The findings from the focus groups aid in developing and understanding the young GBMSN's relationship to sexual health. They may also be instructive for continued efforts to improve the delivery of sexual health services, accessing them. They're broken into 3 parts. PrEP promotion and access, tailoring work for young people specifically, and sexual health beyond clinics. I'm not going to get into all of the, what we can do, but I do have copies of the report, so if you want to know, you come to find me after. Lastly, I just wanted to close by saying this. Although HIV mirrors the inequalities in the world, this is about equity and not equality. It might take longer, it might be more work, and it might be more difficult to improve the sexual health of young queer men. But just because it's more difficult doesn't mean we shouldn't do it. Thank you.
Brilliant, thank you very much. Again, smack on time, love it. So that just leads us on now to present our final speaker with this fantastic panel. So I'd like to introduce Renee West, who is the Development Manager for the GMI Partnership and Positive East. So she's held this post for the last 6 years. Renee holds a doctorate in public health from LSHTM, London School of Hygiene and Tropical Medicine, and a master's in health policy and financing from the London School of Economics. So Dr. West has worked in public health for over 20 years with organisations and institutions in the UK, in the Caribbean, Europe, the US, and includes UNAIDS, the Pan-American Health Organization, and the Pan-Caribbean Partnership Against HIV and AIDS, as well as LSHTM. During this time, Renee has dedicated over, oh, that's me beeping, thank you. That was when you were going to finish. During this time, Renee's dedicated over 16 years to HIV research, programming, and planning. Her HIV research specializes in using qualitative approaches through community, participatory, gender, and equity lenses. She also has interest in the impact of how anthropogenic changes in climate impact on health, and actually this might be a conversation where some of these things need to start intersecting, as Kevin was saying earlier, thinking about things in new ways. So please welcome Renee.
Thank you, everyone. How do I beat those two brilliant presentations earlier? Okay, so good day. I declare that I have no conflicts of interest. And just in case you did not know, the GMI Partnership is a collaboration of 3 London-based HIV prevention and support charities, Metro Charity, Positive East, and Spectra CIC. They provide pan-London community-based sexual health services to diverse communities across London, including, but not limited to, the LGBT+, and Black, Asian, and other racially minoritized groups. As background, in 2018, a London-based PrEP champion project demonstrated gaps in PrEP knowledge and usage among key groups with a significant HIV risk. This present study, conducted by the GMI Partnership, follows up with in-depth focus group. Its objective is to explore PrEP awareness, access, and adherence among people from Black, African, and Caribbean, Latin, gay, bisexual, and men who have sex with other men, and trans and non-binary communities. I'm not going to go through all the demographics, except to say that across the different communities, most common genders and sexualities were represented, and we had a wide age range of participants. The actual number of participants were limited, so there can be no direct generalization to the entire London population of the different communities, but that was not the objective of the study. As an opening question, and to better understand participants' attitudes towards PrEP and provide some context, the participants were asked, do you think that PrEP would be good for you? If so, why? Overwhelmingly, and to be expected, the answer was yes. Using PrEP as a means of preventing HIV was a consistent belief among all 3 communities, albeit with a different understanding, a slightly different understanding among the different populations. Within the BAC community, participants thought that PrEP would provide an additional level of protection, for example, in case the condom bursts or their partner forgot to take their ARTs. Within the Latin GBMSM participants, it was believed that the use of PrEP encouraged more regular HIV testing. And with the trans communities, participants thought that the greater PrEP awareness would encourage more discussions around HIV prevention. Similarly, the theme relating to empowerment and mental health impacts had different interpretations within the different populations. For the Black, African, and Caribbean participants, this related to taking back control of their lives and the mental health impact of receiving a positive diagnosis. For the Latin GBMSM participants, this meant empowering individuals by giving them control over their sexual health and reducing anxiety in sexual encounters. For the trans communities, empowerment, and mental health impacts meant that PrEP awareness will lead to more appropriate HIV prevention services. Physical health impacts by participants in the Black African Caribbean community were related to progression to AIDS and how PrEP might prevent that, whereas physical health impacts by participants in the Latin GBMSM community were related to encouragement, that PrEP would allow for HIV prevention and treatment as well as other diseases. Participants from the Black African and Caribbean community also viewed PrEP from a public health point of view. The more widely PrEP is used, the slower the transmission of the virus through the population. Some individuals, particularly sex workers of the Latin GBMS cohort, experience financial benefits from PrEP use. So what were some of the avenues for information dissemination and access and receipt of PrEP among the different communities? With regard to information dissemination, all participants stressed the need for greater awareness. Trans participants spoke about there not being any visibility to see other people like themselves who might already be taking PrEP. If you can't see it, you can't be it. And the desire for more queer-friendly spaces where they could discuss and disseminate PrEP information for themselves. The use of digital and online technology for increasing awareness was also deliberated. For example, using QR codes on posters to help direct people to more information, as well as how to access PrEP. BSc participants also spoke about healthcare providers engaging in more discussions with BSc women. For access and receipt of PrEP, participants discussed the use of pharmacies and ordering online with discrete packaging for home delivery. BSc participants also discussed the use of vending machines or a model similar to the Amazon pickup and drop-off service once all the health checks were done. Access and receipt from healthcare providers within the BSc community received mixed reviews. Older BSc participants indicated that they would prefer to access PrEP from their GPs rather than a sexual health clinic due to the HIV societal stigma associated with the sexual health clinics, whereas the younger BScs said they would use online services first. This can be partially explained since many of the younger participants were not registered with a GP. Latin participants preferred to use sexual health clinics because they could also have their tests done there. Medical transphobia was discussed as a barrier to access and receipt of PrEP by some of the trans participants, and thus the preference was for a community setting or online ordering. For both information dissemination and access and receipt, participants from all three populations suggested a community outreach model, such as the use of a sexual mobile health clinic. Thanks, Mike. These lived experiences produce a rich spectrum of insights about the potential barriers and facilitators to PrEP adherence. Some of the barriers discussed among the BSc and Latin GBMSM participants included side effects of PrEP. The Latin participants were also concerned about drug interactions with other medications such as antidepressants. Other barriers were lifestyle and everyday habits, such as just being able to remember to take one's tablet. Also work disturbances and interruptions, such as in the case of sex workers, when they go to a client's house, they can spend up to 24 hours and lose track of time. Among the trans community participants, additional barriers for PrEP uptake and subsequent adherence were concerns about the potential for PrEP shortages, historical marketing of PrEP to only GBMSM, and the belief that there was a cost attached to accessing PrEP. This belief that there is a cost demonstrates the lack of awareness, uptake and use among the trans community. Facilitators discussed and suggestions made by participants to overcome barriers to PrEP adherence included the use of pill boxes, alarms, and getting into a routine where, for instance, you would take your PrEP tablet as soon as you had breakfast. PrEP injectables were also discussed among all communities and were found to be particularly favorable among the BSc and Latin communities. So, my take-home points. We need to increase PrEP awareness and expand access and receipt venues. Like Mike, we also have a bus. This was also mentioned in Phil's presentation. But barriers to PrEP adherence include side effects, potential drug interactions, and busy lifestyles, some similar to the queer participants in Phil's study. The importance of tailored community outreach models informed by lived experience in achieving and overcoming the previous points cannot be overstated. My call to action to you. As we have heard, all three populations suggested community outreach models, including a mobile clinic and trans-friendly places for information dissemination and access and receipt of PrEP. The 2024 roadmap for meeting the PrEP needs of those at significant risk to HIV has stressed the need to reduce inequalities in PrEP access, uptake, and use among the global majority and other key populations with a significant HIV risk, including those in this study. PrEP is currently provided by specialist sexual health services. However, there is room for improvement in other settings, as acknowledged by the roadmap. Community organizations like Metro, Positive East, and Spectra have already played a major part in increasing knowledge and awareness and changing attitudes towards uptake and use among key groups. In particular, BAC heterosexual men and women, other racially minoritized GBMSM, as well as trans and non-binary populations. The roadmap is cognizant of the important role that the broader HIV voluntary and community sector play in ensuring equitable and effective PrEP use. And as this study has demonstrated, the key groups want us to play a role in achieving this. In the words of Winnie Byanyima, UN AIDS Director, communities are not in the way. They light the way to the end of AIDS. Let communities lead. I would like to acknowledge the other researchers and authors without whom this enlightening piece of work would not have been possible. Marcia Hoyt, Vix Thompson, Leonardo Pavam, the GMI Partnership Community Workers, Dee Wanks from Spectra CIC, Emma Jones and Anders Nielsen from Metro Charity. I would also like to thank City Bridge Foundation for its support. And finally, I would like to thank the participants who gave of their time and insight. Thank you very much.
Wow, thank you very much. And Renee, I particularly appreciate you kind of drawing the threads through, right? Because actually we're hearing a lot of themes coming up that have similarity and some difference, but quite a lot of things that are sitting together. And I just think that there's so much for us to reflect on. So I'm going to start with a question that I don't want you to answer immediately, but for you to maybe answer at the end. And all of you can too. So given that the theme of the conference is equity and impact, I'd like you to think what you think the primary structural cause, and you have to pick just one, might be that's most responsible for all of these inequities in relation to PrEP access that everyone has been focusing on in terms of your interventions and your research. And once you think about that priority structural cause, then what is your priority demand for addressing that structural issue, and who is that demand to be focused upon? For instance, who is the policymaker? Who is the decision maker who needs to own responsibility for that demand? Okay, so that's for you to ponder and for you to ponder as you also think about your own questions. And we have someone who's got I'm going to carry around a microphone, but this one doesn't work. That's fun.
This one does.
Yeah, but then you don't have a mic. Yes, it does. So thank you so much. So reflecting on some of the questions that you'd like to bring to our speakers, who has something on their mind? Okay, I see a hand there, the person in the blue shirt. And if you're comfortable to say where you've come from, what brings you to the conference, that would be grand.
Yeah, I'm Debbie Flanagan from Gilead Sciences, and we're a sponsor today. Can I just say, first of all, thank you very much to the three of you for your presentations and for the work that you are doing in this prevention space. One of the questions I've got is for Renee, actually, and it's your BAC population that you've interviewed. I'm here, Renee. I'm behind. So it was the BAC population because you've got your Latin GBMSM. What proportion of your BAC population were heterosexual women compared to men as well, and your GBMSM?
Okay, so I really can't remember everything, but the BSc, you asked about the sexuality, basically.
Yeah.
Okay.
So your sexuality and how many were GBMSM compared to heterosexual as well?
Actually, it was kind of like split right down. So we had about 7 straight BSCs, and we had about 7 GBMSM.
And women?
Women, we had 8 cis females and 6 cis men.
Fabulous. Thank you very much.
Okay, you're welcome.
Brilliant. Thank you very much. Thank you. More questions and thoughts? Yes, please.
Yes, I can probably speak loud.
We're recording, so we do need the...
It was just a question for Phil, actually. So I'm Steve. I work up in Norfolk with the NHS sexual health provider, and I just heard you make reference to Grindr, and we try and do some sexual health outreach on Grindr. And I was really just trying to find out whether you did it under the auspices of what you were, or whether you just had a sort of a fairly anonymous profile so that they didn't really know what you were doing on there.
We have used NetReach on Grindr before. But there's been times where the accounts have been removed and stuff like that.
Okay.
We've spoken with Grindr sometimes because if we say this is our account and this is the phone that we're using, they can sometimes allow you to do that because it works in their benefit. But the way we did it was through, like as soon as you open up Grindr, it has that pop-up message about something. We did it through those. We did it through broadcasts as opposed to like contacting people. So,
okay, that's cool.
Yeah.
Great, thanks.
You're welcome.
In the middle, in the white shirt here.
Hi, my name's Johnny from Positive Health Lincolnshire. My question's for Mike. We do a similar thing of going to like on-site, like PSC sites and things, and doing testing. But we've tend to found we rent a camper van, like just an anonymous camper van, and take it testing because having like branding and things, a lot of MSMs don't like that. Have you found any that people don't want to come and talk to you because you've got a branded van or anything like that?
Sometimes it's half the people there like the fact it's branded and like that they can see it, and the other half are like, why are you here? And honestly, it just depends on the day. We usually broadcast it on like Squirt and Grindr and other platforms like that when we are going to be there, and be like, we'll be here for like an hour and a half, then we'll get out your way. We're just here in case anyone needs it, and then we leave. Some people are kind of like, why are you here? Like, you're drawing attention to this. This is against the whole point of this place. And then the other half are like, oh, it's really great that you're here. Depends on the day. But we have experienced it both ways, really.
How do you get around the people that don't want to come and talk to you if there is branded? Is there a way, or is it kind of like they're not going to talk to you either way? So
yeah, it's basically like they're not going to talk to you no matter what. We do a lot of outreach that's not on the bus, it's just in our cars. So we kind of try and cater to both. The main PSC area that we go to is quite big, so you can kind of hide away in a corner somewhere, and you can kind of stay away from the main area of it and be like, we're just over here if anyone needs us. Yeah. But yeah, to be honest, we've seen more positive than we've seen negative. And when the negative does happen, you kind of just have to go with it.
I think it's also fair to say, actually, you're training those other people in other sectors is also how you're going to reach the people who are never going to come up to a branded van. So I think that's I think it's fair to say that's also an important part of it.
Well, hopefully that was the point of the training. So fingers crossed it worked.
Or Patricia could have like a dress on one side and nothing on the other side, you know. So she could kind of be. You could park her one way or the other, and see. Actually, that would be a really interesting test in terms of seeing if people will walk up to the white side of the van rather than the branded side of the van. But that's just me being weird. Okay. Yes, over here. Good exercise for our volunteers. And keep thinking about those questions that I asked because they're coming back for you.
Hi, everyone. My name is Stephanie. I work for the Caribbean and African Health Network. My question is to both of you, because as Caribbean and African Health Network, we work a lot in the community, and most of the community engagements, we invite people like you to come with your bus and do some testing. And I met with someone from the African Advocacy Foundation, which I usually invite to some of our events. So the problem is, it's around stigma, language, and sometimes we work with asylum seekers and maybe refugees, and some of them, English is not their first language. So my question is, do you have people who can interact, example, Somalians who can speak English? Do you have people who can interpret to them? And some of them, as asylum seekers or refugees, they're not registered with the GP. For example, if they need PrEP, how can you help them? And again, another question is to both of you again. I know about PrEP, but I don't know if we're going to touch on post-exposure prophylaxis, because some people already have encounter with someone who didn't prepare for, and in order for them to be safe, how can they get that help? Maybe emergency help or something. So have you provision for something like that?
So is that for all of us?
Yes.
Okay. Sorry, I wasn't sure. Does anyone want to take it?
Hi, thank you very much for that question. Very good question. As far as, yes, language barriers, there is an issue not only with the Black African, but for a lot of the communities and the asylum seekers and refugees in London. There is an issue about language. With some things, yes, we do have interpreters, translators at the actual site. We also have documents and other PrEP documents translated already. The other question that you asked about was about getting, I'm sorry. PEP. We will talk to you about PEP if there are issues. We don't actually give out. We will try and signpost you as to where to get PEP and or PrEP. That was it? Okay. Thank you.
Up in Lancashire, obviously it's different. Within Lancashire, you don't need to be registered with the GP to get PrEP. So they can go to sexual health services, and that's completely separate. So even the ones that aren't registered with the GP can still access PrEP. In terms of PEP, we have very clear pathways that we've made with clinical services as to where people can go to access PEP if it's needed. And then along the testing for people in asylum seeker communities and things like that, quite a lot of asylum seekers in Lancashire are still in hotels, and we do testing at the hotels and signpost to different services as well. The clinics that we work with do have translators that they can contact if that's needed, and the hotels themselves also have translators. And same as Renee, we have our literature translated into different languages, and then we also make use of our websites as well. Our websites can be translated live through Google, so that has become an increasingly useful tool.
At the Love Tank, across all of our websites, a lot of our information is available in like different languages. We have like, I think it's 7 is the typical number that we do. But I think the issue that we have is that in clinical settings, people that speak different languages don't know that they can ask for interpreters. So I think that's where the issue lies in that. A solution off the top of my head would be to book with someone that might know the system or something along those lines. And as for PrEP, there's been a huge shift, I think, since PrEP has become more available, in the sense of like conversations about PrEP are just not had as much. I think it's a lot more difficult to access, but it's also partially due to how successful we've been in this country with some of the advancements with HIV.
Yeah, thank you very much. Okay, so then heading back to that original question that I asked, and we're on the road to wrapping up the session. Think about sort of the one big one for you in terms of structural causes of these inequalities that we're looking at, and whose door do you want that to land at, Renee?
Okay, I may be getting in trouble on wading in waters that I should
It's
not
like
be.
You're being recorded or anything.
But I think, as far as structural inequalities, I think the health system has a big part to play in this. For example, and I think Professor Fenton coming on with the second HIV action plan is great, and I'm sure he's going to keep his promise on that, but I'm going to make sure that he's behind that as well as the minister. And also the PrEP guidelines, and I know they're being updated to allow access to everyone. For instance, as I mentioned earlier, PrEP was targeted mainly to GBMSM. The guidelines basically, they say that everyone can get it, but in practice, that is not so. Yeah. And I speak particularly for women, right? We have had cases where we have taken a woman who's obviously in need of PrEP and who could benefit from PrEP. We would take them, we would walk with them to their appointment. They would be refused, or they would be asked to come back so many different times.
Okay, so what's your ask?
My ask is that these new guidelines are very, very specific, and that that everyone can access them.
Brilliant. Okay. Phil?
Thank you.
I think mine is structural racism. I think structural racism has such an impact on healthcare across so many different parts, HIV including that. I think my ask is to everyone. My ask is to governmental bodies, the NHS, everyone in this room, everyone at this conference. I think a lot of the time we acknowledge that racism is an issue within HIV prevention, but then not much comes from that. So, yeah.
Okay, thank you. Mike?
Mine, Lancashire is a big place, and there are only 5 clinics in the whole county that offer PrEP. PrEP needs to be available in more places, in more venues. It needs to be available to those who don't live in a city centre, and it needs to be available in more settings, not just clinical. And I think my ask is to the guidelines, to BASH. Those guidelines need to be more encouraging and more...
Okay, BASH won't make that clinical access happen. So the ask is to whom?
I think the ask is to the ICBs, the integrated care boards, to say you need to look at this as a real issue that people are... I talk to people from villages in Lancashire that are saying, I don't have a way to travel to that place. I can't do this. When there is a sexual health clinic right down the road from them, it just can't offer PrEP. And I think that's probably my biggest one.
Brilliant. Okay, we are stopping there, but thank you so much. And please thank our speakers once again for a really great session.
It's actually now not Stuart Smith who's going to be presenting. It's Dan Lusky from National AIDS Trust, but I can introduce him if that's easier. So if it's easier for you to introduce me and then I will introduce both of us, that's fine. Yeah, Stuart will be winging it anyway, it'll be fine.
I just presented, so it's like,
Oh, yeah. I was going to say, I've got notes on my laptop. I was going to try and check that I can kind of get that into a view that will work and still see. Like, I don't know what I'm. If I do It's definitely Friday and we've got It's a good question. Yeah, it is. Okay. And when you do the
well, these, okay. Okay, I think the flow of people has lessened now, so let's make a start. So this whole session's about opt-out testing in ED departments, and to start off with, can I introduce Katie from THT, who's the Policy and Public Affairs Manager at Terence Higgins Trust.
Hi everyone, and I'm going to bring Dan Flusky from National AIDS up onto the stage with me as well. So I was initially doing this presentation with Stuart Smith from the Hep C Trust, who I think actually he sends his apologies but might be watching us online, so is here supporting us as well. And we're doing this presentation on behalf of Terence Higgins Trust, National AIDS Trust, Hep C Trust, the British Liver Trust and the Elton John AIDS Foundation. So we've all pulled these slides together. And really, I think we're doing this presentation on behalf of all of us in this room, in the sector, because I don't think there's anyone in the HIV community, whether it's a clinician or a community member, a commissioner, who hasn't in some way been involved in this campaign for the expansion of opt-out testing. So this really is a kind of presentation about the collective effort that we all made to advocate for an expansion of the opt-out HIV testing programme that started in A&Es in London, Blackpool, Brighton and Manchester, and that's now being expanded out by the fantastic team at NHS England. So with that, I will hand over to Dan to do a quick overview of how we got here, and then we're going to tag team these slides. So let's see if my clicker works to start off with. Yeah, there we go.
Shall I grab that? Proceed. Thank you, Katie. Hello, everybody. And if we're talking quickly, it's because we have been told we have got 10 minutes to get through this big change. Just so everybody kind of is starting off on the same footing, so it's a simple principle here that we were talking about and campaigning for, that everyone who has their blood taken is tested unless they specifically ask not to be. We started off with clear evidence that we knew that it had been working and had been successful in maternity services. There was some great work done by the Elton John AIDS Foundation, trialling opt-out testing in A&Es in South London, and as well as kind of all of the great campaigning and the work that we did from the kind of voluntary sector side. As Katie said, everyone was kind of an ally here for this. We were trying to kind of work with people to align to all get the right policy taken on, and that was including kind of working with and following recommendations by Beaver, Bash, and so on, and clinicians. So it's a mix of charity sector, people working, civil servants, inside government, and clinical expertise as well. And just to kind of go back a second, so Kevin mentioned this in his session this morning, but I think it's really important just to kind of remember the chronology of where we came from and where we got to. So Katie and I from THT and NAT, as well as Elton John AIDS Foundation, were the partners of the HIV Commission, with the commissioners looking at what we need to do in order to get to 2030, and one of the key pillars of that was testing and testing and testing, and a clear call that HIV testing must become routine and opt-out, not opt-in, across the health service. The action plan that we've got at the moment, 21 to 25, was in response to the HIV Commission, and it was published in December 21. And in that action plan, it was committed that there would be £20 million for opt-out testing in very high prevalence areas: Brighton, Manchester, Blackpool, Salford, and parts of London. And that was a really key step to have that action committed to in the government action plan to take this forward. And I think I'm going to now hand over to Katie, which is, where did that 20 million go? What did it do? And what next?
This is where hepatitis comes in. So when NHS England started rolling out the programme, the fantastic people in the HIV team and also the Hep C Elimination Fund got their heads together and decided that it made logical sense for this programme to be a bloodborne virus programme rather than just an HIV testing programme. We owe them enormous gratitude for that foresight that they had, and so that meant that the programme was able to take place across all of London, not just areas that had very high prevalence of HIV in London, and it also meant that it was able to include Hep B and Hep C. So hospitals across 4 cities started with that testing. And it was success on all measures. This will be familiar to lots of people in the room, and we repeated these 4 things in briefings to MPs, politicians, again and again, in meetings, in written briefings, in letters, that the opt-out testing program, when it was rolled out in those areas, was saving lives, it was saving money, it tackled inequalities, and it relieved pressure on the NHS. And you'll see from the data on those slides there, which was provided by all of the fantastic people working on the program, that we had the evidence to back that up. And I think that was one of the really key reasons that we were able to make this case, is we had really robust evidence that we could take to MPs and we could take to government to show that this worked. So I just also next up want to talk quickly about the community sector involvement. First, in the rollout of the programme and why that mattered for all of us as community organisations in campaigning for the expansion. So because we as HIV and hepatitis organisations were involved in the inception of the programme and all of the working groups that rolled it out, it meant that we got to know each other better. So us in HIV World, National AIDS Trust, Terence Higgins Trust, Elton John AIDS Foundation were familiar with working together already, but getting to know the teams at Hep C Trust and British Liver Trust as part of this was new. We're not so used to working as bloodborne viruses in general. If Stuart was here, he would ask me to emphasise, and he would be emphasising the role that he really felt that patient voice played in developing that programme and the importance of that, and that the role that that had in the programme being a success. But it also just meant that we all got to know each other better. So as we started to form the campaign to expand the programme, we were working as hepatitis and HIV organisations together. So just here, this is the campaign for expansion. You can see on the slide there an e-action that was on the British Liver Trust website, and this was an action that we all did together. So we wrote an open letter to the Public Health Minister and to Amanda Pritchard. There was a lot of change in ministers during this campaign. So I think we had 3 health secretaries and 3 public health ministers. So we all briefed them multiple times, new MPs, it moved into the ministerial positions, and we went again and again. But this particular open letter that we wrote went to Neil O'Brien, who was Public Health Minister for about 9 months last year. There are lots of community organisations in this room who added their names to that letter, and it also went out as an open call to our supporters, so it enabled us to just get a really clear ask and some publicity for our campaign. We also contacted all MPs who represented areas with a high prevalence of HIV to tell them that the recommendation said that their hospital should be doing this testing, and so that they themselves could also ask the Secretary of State for that funding. So individual MPs were writing, raising this in Parliament, as well as us having this big collective ask, which was really clear. So we facilitated those letters, 3 rounds of those letters to different health secretaries up until November last year. And at that point, there was one more change of health secretary. So Steve Barclay moved to Victoria Atkins, and in the end, we got it over the line. I think not we, but Sir Elton John got it over the line by, he was honoured at a very fancy reception in Parliament for World AIDS Day. It was hosted by the APPGE, and we again collectively were able to say to the health secretary that it would be a good time to make a big shiny announcement about this expansion, and we had this enormous coalition of MPs, civil servants, people working on the programme, charity organisations who were all in line saying that same thing and making that call. It was actually the first funding announcement that Victoria Atkins made as Health Secretary, which I think we can all be very proud of. And the reason for that was that this was a case that was waiting on her desk for her, because we'd all collectively made a really strong case there. So it's £20 million. I know that the future presentations that are coming are going to talk probably more about this. £20 million for 47 more hospitals, which means that now 81 hospitals in England are doing this type of testing, and it's 12 months of funding from the National Institute of Health and Care Research to be spent from April 2024 to 26. So we've got 1 year of funding at the moment, although those who listen to Andrew Gwynn this morning will hear that we're already hoping to start campaigning for an expansion of that. Really crucially, and again, this is credit to the team at NHS England, 10% of that funding is going to HIV community support. So there'll be support for people who are getting a new diagnosis, but also for the cohort of people who are need to be re-engaged in care, so who are being diagnosed, re-diagnosed as they pass through emergency services, and the Hep C Elimination Fund are matching that again. So I'll hand over to Dan for a what next, because this is always only just the beginning.
Yeah, absolutely. I mean, one of the things in policy world is that you have to keep making the case and keep making the case and keep making. painting that bridge in Scotland, get to the other side, you have to go back and start again. So with the new government, we're continuing to kind of push for the success of opt-out and its continuation and sustainability and expansion. We know there's cliff edge of funding currently, which we need to get expanded. And we need to look at multi-year funding for all areas and look about whether there's potential expansion into new hospitals and to continue the programme, because this is one of the key things. If we're going to get to 2030, opt-out has to stay, it has to get bigger, it has to expand. And when Kevin was talking about kind of, you know, a new action plan in 25 to 30, one of the things that we're really, really focused on is there's not enough time to get things wrong. We need to work out what is going right and double down on them and accelerate that progress. And this is one of the clear and obvious things, which it does cost money, but we're going to have to spend money if we're going to get to 2030. So we have to double down on the things that we work. But we're working with a new government. You know, we have to kind of establish those relationships. There's 300 new MPs. We want to get as many as possible on side. We've got 7 months until the hospitals and the very high prevalence face the funding cliff edge. So that's why we need to make that case now, and we need to keep making that case over the coming months. And we're going to be scoping this out a little bit more as well. So Katie and I and Richard from Elton John AIDS Foundation are doing a workshop this afternoon, kind of looking at the action plan and what next and what are those actions. And some of this is going to be about how do we take opt-out testing forward as part of that next action plan as well. There's an alarm going off and someone has just waved a piece of paper with minutes on it. So I think it's time for us to jump off the stage and the next people, and then I think we do questions together at the end. Thank you.
Fantastic, thank you. I suddenly realised I just dashed from doing a previous presentation. I didn't introduce myself. So I'm Jeremy Hoard. I'm a professor of social sciences at the University of Bristol, and I'm involved in the opt-out testing as well. So next, we've got Sue and Chris. Yeah. So Sue's an HIV nurse specialist in Blackpool and has worked in sexual health and HIV since 1990. And so co-leads the opt-out testing programme that commenced in the Blackpool ED departments. And Chris has 14 years working in sexual health. And Chris is an HIV clinical nurse specialist. And Chris is a co-project lead for the implementation of opt-out testing within their emergency department. So, take it away.
Fabulous, thank you. Yeah, so here we are, we're going to do a double act, Chris and I. So, Chris is going to press the buttons, because he's best at doing that. Okay, so thank you very much, Jeremy, for the introduction, and obviously we're following on from what Kate and Dan said, yeah. So I'm Sue Potts, clinical nurse specialist for HIV in Blackpool, and
I'm Chris Hodgson, like I said. So I currently work in a city of Preston, which is just down the road, about 2-3 miles. That's not a bit more than that, isn't it? Down the road from Blackpool.
15.
But I'm born and bred live in Blackpool, and I've had, when we first started the implementation of this programme, I did move to Preston, but I was like, I'm not letting go of this. Because unfortunately, at the minute, Preston isn't in that, in the high prevalence for the opt-out screening. So I've put a lot of work into this with yourself and Sue. So, yeah, so I've not let go of it just yet.
No, we don't want to let go of it. So, for me, HIV testing has been part of nearly all my working life. I'm old enough to remember when it came into place for maternity in 2000 and was involved in that and all the fears and concerns that went ahead for the midwives at that time. And then we had quite an innovative doctor in Blackpool in about 2013, and we started doing routine testing in AMU. And again, I tried to lead on that. It was very, very difficult, very hard, but obviously we had no idea that this sort of programme was going to be coming into the forefront, 10 years later. So that sort of set me up for that, and then everything went on the back burner, and because a colleague left and there was just nobody interested in doing it. Nobody wanted to take charge of this, and there were so many moans and complaints, and a colleague wanted to do it for his dissertation in ED. So we actually did that, but about that time COVID hit, and that was all the issues with that. So we started it and we stopped it, and that was when we all got into Zoom meetings and MST meetings. And Chris and I did a presentation for THT for HIV Testing Week, and we were quite good on that. We said what Blackpool was like, you know, and what we're doing, and, you know, outside of London, that we're actually doing something up north. You know, we're not just all about donkeys and kiss me quick hearts at Blackpool. We caught somebody's eye for whatever reason. When the ED testing, people were looking at who was going to go into that cohort, they realised that outside of London and the 17 sites that were being chosen, Blackpool was also the second highest after Manchester in the northwest. So we were kindly invited to go along and given some funding.
Yeah, so as we said, like we talked about the 20 million before, so part of that, the trial that our colleagues in ED started, so it was anyone that attends for a blood test, so normalising that testing as part of the attendance, obviously when the blood is drawn, and which will help reduce HIV stigma. And obviously we wanted to reach communities which were underserved by testing opportunities and reduce the number of people presenting with late diagnosis. And from obviously the evidence that is out there, because of the 2 years that are there, obviously it's highly cost effective as well. So just go on to the next one. So what did we do? So as you can see there, we've got our poster that we created that is based on the national programme, and also the information leaflet that we have around the ED department. So, like we said, whoever comes in for any blood tests, they will have initially the HIV test would be taken, and then we also implemented Hep B and Hep C testing as well further on.
So because obviously we're healthcare professionals, there's all sorts of hoops to jump through before we can actually get some sort of movement and ongoing action within.
Hello. Sorry.
Right, we'll move
Because
over.
you're not here.
So, obviously we got all sorts of hoops and everything to go through. The policy took forever to get engaged, and there's always people that want to put a spoke in the works. There's always people not keen on it. But we keep bouncing back at them, and we keep, you know, doing our challenging and saying how good it is, and trying to feed back everything that we actually do, and try and keeping them engaged. We needed to develop our own KPIs, performance indicators for the commissioners, so as they knew what we're actually doing, and obviously so we could also feed back to NHS England as well. So we did develop our own KPIs to keep us on our toes, and we set it at 65%, but when we started out we were failing miserably because people didn't want to know. We were going about 26%, so people were just slipping through the net, and people then were thinking that they were being tested, so it had to go on the trust risk register, because if people think they're being tested and then later find out that they're positive and say, why did I never know, and we don't know that they hadn't been tested, we could look back exercise, you know, we're in trouble there, because we're advertising that, hey, we're doing this here. So there's been a lot of challenges, and as I say, a lot of unsettlement from healthcare professionals, and again it goes back to stigma and equality, you know, and why should we be doing it, you know, why should you know, we not just target certain people. Now, with the figures that Chris is going to explain that we've picked up in the last 2 years since we're doing the programme, there's a chappie on there that I just got last week who's 84. Now, he went in with completely unrelated HIV, anything to do with HIV at all, and that just goes to show that, you know, anybody can get it. And if somebody had just been looking at him, would they have thought they would have tested him? No, 84, you don't have sex, so, you know, you probably wouldn't have been you know, involved in that programme. They would have just assumed not to. So as I say, there's a lot of barriers, a lot of education that we have to try and do, you know, but we've developed our education programme, haven't we? We do a rolling programme of that, and so far we've trained over 100 ED nurses. The medics are more difficult to engage, unfortunately, because the lead medic for us in Blackpool has been difficult to engage with. I'm trying to put it diplomatically. We couldn't see the benefit of it. And seeing as Blackpool is one of the most deprived, in the top 10 of deprived areas in the country for suicide, poverty, inequality, you'd think that, you know, somebody would be really keen to actually move with something like this, especially for, you know, NHS England choosing us. Anyway, we keep turning up, don't we, Chris? We're like bad pennies, so as they can't forget us and know that we're still here. So
as you can see there, like Sue said, we developed a training programme to train all the staff, including nurses, HCAs, assistant practitioners, nursing associates, etc. Unfortunately, obviously in ED, because of the pressures, there is a high turnover of staff, so we do this on a rolling basis. It's a 2-monthly basis, and like it is mandatory as part of their training as a new initial. And that talks about obviously the background, why it was implemented in Blackpool, the importance of it. We talk about case studies, missed opportunities. So it is quite an extensive, it's a 2-hour training session, but the feedback we've got from that is we've had very good feedback, and it has, since we started the training session, like Sue was saying, we were hitting around 26-30% of people attending for bloods, having bloods taken. It jumped right up to around 80-85%, just implementing that training and getting the word out there. So it was a really successful training program, and that's where we are trying to get into the medics program, but that, like we said, we are having a couple of issues with that. So you can see there, I don't know why, but obviously Blackpool, it's a transient population, and it seems when anyone wants to come to the seaside, they visit A&E as well. So you can see we have high numbers of people attending for the screening. So since we've started, we have had 15 new. So from there, it does say April 2022, because we did the pilot scheme ourselves. So we've had 15 new diagnoses, plus 2 partner notifications. So obviously, when we found someone in A&E, we obviously complete partner notification, and we've had positive results from that. So obviously, it stops onward transmission as well. 5 were known positive, but we re-engaged within services. So again, it helps because, again, like I said, people come on holiday to Blackpool. They might not be in the service in a local area, in their own area. So they've disengaged, they've come out of service. So we're able to, if we got a positive result and they're not known to us in the area, we contact them, find out where they're living. If they're new and they're moving to it, we'll take them obviously under our care. If not, we'll refer them back into their service, check that they are under care. So you can see also there, we work very closely with our liver team as well. We've had 18 new hepatitis B, 35 new hep C. And like Katie was saying before, the work that we do now with the liver service, they provide the training session with us as well, and we've got a great working relationship. And then you can see remaining 129 positive screens. They were obviously positives that were known to our services, and like I said before, other services. Thank you. So the only issue that we are still working on, well, a couple of issues is we do get rejected screens, approximately about 50 a month, and it always stays around that figure. And it tends to be, we take an extra blood bottle. Sometimes it goes in the wrong blood bottle. They don't get labelled, etc., etc. So it's more the education and the training. We're hoping that will reduce. One of the big things that we found from the feedback, I provide a monthly dashboard each month, which goes to all the nurses on their sort of staff notice board, etc., about the number of screens done, if we've had any new positives. And like I said before, we do feedback the new diagnoses to show, obviously, the impact is just having that opt-out screen has had on them, and obviously if a lot are late diagnosis.
Yeah, so those 15 new ones that we've had, 9 of them have been late presenters, i.e. with a CD4 count less than 350, which obviously, you know, morbidity and mortality comes into play there. 8 of those 15 have been missed by the GPs in the community setting, and 2 of the GPs had referred them on to the hospital, and they'd been further missed by the services within the hospital and the speciality that they'd been referred to. And whilst we try and educate, it's very, very difficult. And this is where, you know, people just don't want to know, healthcare professionals. 7 had no symptoms whatsoever, which was great. We've caught them early enough to, you know, keep them well and help them with their life. And the partner notification, the 2 patients that were picked up from the fact that their partners were positive, neither of those had symptoms either. We do share with them the success stories of people that we picked up, but equally we share with them the sadness of people that they've missed. And one man in particular plays on our minds, a 40-year-old gentleman that sadly passed away because 3 times he went into ED and 3 times he wasn't tested. Whether the outcome would have been different, I don't know. But his partner, instead of they were planning the wedding, he ended up cancelling it and obviously planning the funeral. And it is very emotive, that, and I think when people hear that sort of thing, and it's not to point fingers of blame, it's just to say what can happen, because you can't judge a book by its cover. None of us in here know what each other does sexually. It's none of our business, is it? So therefore, we cannot judge patients by that. So the challenges that we have, next slide, Chris, because I'm sure we must be running out of time. Challenges are numerous. COVID obviously was the first one. However, you know, it ended up being 2 minutes, thanks. Oh, like that. It ended up helping us because obviously that was where people were engaged on Teams and everything, and it was we would never have showcased what we were doing in Blackpool at that time if it hadn't been for COVID, and we got our message out there.
So again, initially it was the staff engagement and buy-in. There are still obviously issues with that, but like I said before, just reiterating with the training programme, the dashboard, and we do take, we survey obviously the training sessions. Is there something we need to, you know, bring in, discuss, etc. Biggest one for us, which is still ongoing after all this time, is automation. It is very, very close, but for some reason Blackpool is the only hospital that uses a certain specific system within their department, and to get automation into that computer system, so to get it into an A&E profile, so it's you know, the blood, they don't need to think about it. It's very challenging. I'm sure the new sites that are coming on board, that's probably one of the first things I would advise start off with if you can, because obviously as soon as you get automation, it helps massively. So, and then obviously we've got the leaflets that we are working with to get them in different languages, and obviously because currently it's a QR code, and we have banners and the posters all around the ED department and the leaflets as well.
Providing somebody doesn't take them down if the trust is being decorated.
When they're decorating.
And then, you know, and we have to go back and say, look, it's our informed consent up here, so please don't take them down. But you know, for us, the challenge is we don't give up. We don't give up. We just keep going back time and time again. And with the support from our colleagues at NHSE, you know, we believe that we do make a difference. In the conclusion, you know, our screening programme has gone from strength to strength. We're not automated, so to achieve 85% without automation of bloods is absolutely amazing, and a credit to the staff that take those bloods. You know, and that's not us. We don't do that. We just pick up the pieces afterwards. But we're lucky in Blackpool. We have one lab, and they phone us to let us know they've got a positive result before it is released, and we can look at that and work that out and try and manage that, and that takes away the fear from the staff in ED who think that they might be tasked with dealing with this and perhaps not enough knowledge. So we know that obviously the theme is prioritising equality and impact. What, am I shutting up? Yeah. Have I run out of time? Okay, so we're doing great. Thank you.
Thank you.
Passion really came through there. Fantastic, thank you. Okay, so next up is a project I know because I'm working on it. So I'm co-leading the national evaluation of ED testing, and with me are colleagues is Tom, who's leading the qualitative evaluation of ED testing, and Tom's a research fellow at the University of Bristol. And with him is Siobhan, and Siobhan's a senior research associate in research at the University of Bristol, and Siobhan's leading the qualitative data collection, and they're going to speak to you about what we found.
Thanks, Jeremy. Hi, everyone. Yeah, as Jeremy mentioned, we're going to be speaking about our qualitative work around the implementation of opt-out testing. So this is a qualitative study looking at, as Susan and Chris mentioned, around sort of challenges and solutions that sites face when implementing opt-out testing. So hopefully it should follow on quite nicely from what you guys spoke about. Apologies, this is probably quite similar ground to what we all know already, so I'll skim through it quite quickly. But as we know, in 2022, NHS England launched opt-out testing in 37 EDs in areas with very high HIV prevalence in London, Manchester, Blackpool and Brighton. And through a partnership with the Hep C Elimination Fund, Hep B and Hep C were later added to form a kind of combined approach to opt-out testing. The aims or the goals of the programme really are, as we already know, to meet viral elimination goals. So that's a 2030 goal of reaching zero HIV transmission, and also eliminating Hep B as a public health risk and Hep C transmission. To do this, we need to increase access to testing, so we need to scale this up to reach people that have undiagnosed infection. Obviously, EDs offer a point of care which is accessible to all, so it's able to reach those people that maybe don't perceive themselves as being at risk or face barriers to existing other forms of testing. And finally, by presenting testing as routine care, opt-out testing can also help to normalise testing and reduce HIV stigma. And as the co-presenters have mentioned already, this year we're also seeing a recent expansion of opt-out testing into 47 high prevalence HIV areas. So the pathway that opt-out testing takes, so anyone aged 16 years or over who is attending ED and having a blood test is automatically tested for HIV, Hep B or Hep C unless they explicitly opt out. Patients are informed by posters and banners that are placed in EDs, which also provides information around how they can opt out of testing should they wish to. Patients are contacted by relevant or specialist teams if they have a reactive result, and they're then supported to engage or re-engage with care through those services. So it adopts a no news is good news approach to results management. So in terms of the work that we've been doing at the University of Bristol, in collaboration with UKHSA, we've been evaluating the first rollout of opt-out testing that started in 2022. And there's 3 work streams to this work. So there's a public health evaluation that's been led by UKHSA, a cost effectiveness analysis that's also being conducted by the University of Bristol, and a qualitative study looking at the implementation of the programme, which myself, Jeremy and Siobhan are working on. In terms of the aims of this work, we were looking to optimise the delivery of opt-out testing in very high HIV prevalence areas to increase test coverage and uptake. So looking at what was going on within those sites, looking at any issues, and then feeding that back rapidly to inform implementation. There were 2 stages to the work. So the first stage was to describe the different strategies of EDs to implementing opt-out testing. So last year we published that where we obtained SOPs from all of the 37 sites and looked at any variation or consistency across sites and how they implemented it. The phase 2, which is what we're talking about today, is again looking at those issues and barriers to opt-out testing. So that was through qualitative research with both patients and staff within EDs. And as I've already mentioned, this was looking to develop recommendations to optimise future implementation. So using that feedback to help shape both implementation within very high prevalence areas, but also for the new rollout as well. So in terms of our methods then, we selected 5 ED sites involved in the first rollout, and we conducted interviews with 21 staff involved in the delivery of testing. All interviews were conducted remotely via Teams or telephone by Siobhan and myself, and they were all conducted between April and August of this year. And yeah, as I said, findings identified any challenges and solutions to implementation. And in terms of who we spoke to, we've got a mixture of people. The majority of the people were from ED, so healthcare assistants, ED doctors, nurses, but we also spoke to people within labs as well. and also a HIV nurse and coordinator and a hepatologist as well. In terms of the challenges and solutions, I'm going to pass you on to Siobhan, who's going to talk you through those.
Thank you. Might be a bit smaller. So I'm going to talk to you about the findings that we found, and just to kind of highlight Chris and Sue's work, because one thing that we've seen across all sites is there is people there tirelessly looking at all the challenges and looking at all the solutions. So we were actually really fortunate that a lot of our solutions came from the sites that we were working with. So they were kind of what one site was doing, and so we have kind of said that actually that has worked, and so we wanted to kind of see where those were coming from. So it really is people like Sue and Chris batting down the door, kind of going, let's do this, and Blackpool are one of our sites as well. So you may see some similarities in what we're talking about today. So the kind of one of the biggest challenges and one of the biggest things that was coming across was staff knowledge and understanding. We know from talks this morning, you know, knowledge and stigma still is in healthcare. And so the inconsistencies that we saw across sites were some sites had really good training and some sites had nothing. And also it was some sites, doctors were getting training but not the healthcare assistants. So it was about, looking at those inconsistencies and what happened when there was no training. So the people that we interviewed were really positive about the opt-out testing. However, they still had low levels of knowledge or understanding, and they couldn't talk to patients about it. So there was times where they would just say, I would just say, talk to your doctor because I don't know. So it was about them kind of agreeing with the initiative but not having the knowledge. And also there was examples of outdated views and stigma. And moving on. So one of the solutions is to have really good training, but we also are aware that we have very busy EDs, so we need to make sure that this training is accessible and concise, and covering some key topics. So we looked at some key topics, so information around bloodborne viruses, the purposes of testing and the elimination goals, information about follow-up care, so people could actually kind of one, know that they didn't have to do it, because that's a really important thing for staff, but also that they could tell patients that, you are going to be seen by specialist services if you come back as reactive. And the community support organisations, and that staff know about those community support organisations and the peer support. And one of the big things that came out, and I've just been to a talk that highlighted this as well, was where staff had somebody who was living with a bloodborne virus as part of their training, the impact of that was massive. And they said that was why they understood that this testing initiative was good, and that's why they were continuing to include the test, because they had somebody living with the virus, and they could see even better if that person had been diagnosed through ED, but obviously we're at the beginning of it, but it was really, really impactful, and we can see here from the quotes that was highlighted. So the next one is around how do you embed routine testing? How do you make it going from exceptional tests to actually this is just something that we do? Chris obviously already highlighted the automation. So for people who don't know, some sites have it that when you do a blood set, when you order your bloods in ED, you're automatically the bloodborne virus test is automatically added. So it's kind of little thinking for staff. But not a lot, but some of the sites have funny IT systems that don't allow them to do it, and you're not the only ones, can I say. There is lots of sites that their systems don't allow them to automate. And some sites just can't financially, or for whatever reasons, this isn't going to be a thing. So we had to kind of think about things for those sites that couldn't automate it. How could they be helped? And the other challenge was around the extra vials. So a lot of the times bloodborne viruses are taken in a yellow top, which is the same as the U's and E's, and kind of staff would be routinely just doing one yellow top. And so they were, even if they had it kind of collected, they would just, oh no, I don't need that. Why do I have a second one of those? So it's kind of like, oh no, I don't need to kind of include this. So some of the solutions that we talked about, so in sites that without automation, they talked about having posters up in the staff areas, post-its on the computer sometimes, just like little reminders around bloodborne viruses, and also verbal reminders by the leads at daily huddles and handovers. But these all need people like Sue and Chris who are going to, you know, talk about it, but also people in ED, and the buy-in from ED is really important. And then the other thing that some sites were doing was using a different colour vial. So they were using red tops instead of yellow tops, and that just gave that staff the visual, oh, this is a different test, I need to remember to do it. And actually, it was, in one of the sites, there was a healthcare assistant who thought about this and introduced it within their site. And then one site also has a different size. So just little changes that actually meant that staff were remembering to include it. And allowing time, like change, embedding normal testing doesn't happen overnight. And I think if we expect it to happen overnight, it's not going to happen. So allowing that time, providing staff support and effective ways to feedback. So if they see, look, these bottles aren't working, and making sure those communication lines are open. And again, we see from Sue and Chris, like their numbers went up once they started to implement some things. So I think it's really about embedding it within EDs and giving people that time to do that. So, patient knowledge of opt-out testing. So staff were really positive about the testing initiative and about the fact that it was opt-out. But one thing that they were unsure about, and actually probably for some of them felt uncomfortable about, was whether or not people actually knew about the test. And this wasn't about them getting consent, it was more just about whether, you know, the patient knowledge. Whether or not they're being tested, and also, was this a missed opportunity for some health promotion, health education around bloodborne viruses? What could they do? But on the flip side, we're very aware that they're very busy EDs, and it's not always that easy to do health education. So one of the kind of solutions to this was around having standardized scripts so that people could kind of, if they felt that the person in front of them wasn't informed or may not have known, they could easily say, we're doing routine testing for bloodborne viruses, as part of it. And then also having the knowledge for if that person then asks questions, that they know where to signpost them. They know which website or which, sexual health clinic or where they need to sign them. Okay, I really need to speed up, sorry. So another kind of issue that came up was around workload and competing priorities, and people not seeing this as a priority. This isn't a test, I've got many other things that I need to be doing, and this isn't something. But on the flip side, staff say this takes 30 seconds. It's really quick. It doesn't take over. It doesn't do anything. So actually, it doesn't need to be a competing priority. And I think part of that is about the importance of promoting universal testing and what that does. Sending out emails, this is the amount of people we tested, sending out things to tell them so that you're getting their buy-in, because if they have buy-in, they won't see it as a competing priority. They won't see it as something that adds to their workload, because in reality it doesn't, but it still has that sense of it.
Yeah, I think I've got about a minute to go through these. So, so we came up, based on our findings, we came up with some kind of recommendations that can be used in additional sites. The first of these was to foster staff buy-in, so similar to what Chris and Susan mentioned. Honestly, we hadn't seen your slides before, so we didn't copy you or anything. But yeah, making sure that we promote the importance of testing to all staff. And as Siobhan mentioned, as we've heard before in some of the other talks, having people with lived experience to really kind of promote the importance of it and, make training more impactful is really, really important. Providing staff education and training, so ensuring that all people were provided with training, so right through from people that are actually delivering testing to actually overseeing the programme as well. Supporting ED staff in testing all patients, so at sites that are not automated, using things that can help support them, so reminders in consultation rooms and so on. In sites that are automated, just changing maybe like the colour of the vial top. Efficient patient communication processes, so if there are concerns about whether a patient has seen information, just having like a script or something like that, that can just not disrupt the workflow or patterns of how people are working. Closely working with specialist HIV and hepatology teams as well, so we found at sites that were working really closely with both those specialist services and EDs. EDs felt really supported to implement the programme, and we kind of hope that in sites where we're all implementing these procedures and once it was up and running, we found that actually it really helped sort of normalise and embed testing, and we hope going forward that as the rollout is expanded, we hope that more sites can follow these procedures and help to kind of implement testing as part of a normal part of routine care, just like any other standard test. Just some acknowledgements. So we've got we work closely with UCL and also their HPRU there, and also UKHSA and Fast Track Cities Bristol. If you would like any more information about the study, there's a QR code that links to our website as well. Thank you very much.
Okay, can everyone, is this working? Yeah. Can everyone, the speakers come back to the stage? I think we need to bring a couple of chairs. Gonna run out. Okay, so we've got some time for some questions. I'll let you rearrange the furniture first. That's enough.
Are you going to sit down as well?
No, I'll stand up. I'll stand up. Okay, so there are any questions? Yeah.
Hi, we're from Lincolnshire and we're quite a rural area. When would the opt-out be introduced to more rural areas? And also, there's a lot of people who are against, I wouldn't say a lot of people against testing, but how would you encourage them to take part? Because there's a lot of people who are not knowledgeable enough to, if you know, I'm mumbling, but obviously educated, and how would you promote the testing as well?
No, say that. There's a microphone on the table.
Is this working?
Yeah.
Yeah, so I think, well, one of the things from our point of view with the expansion has been that we had these really clear recommendations from NICE and from BEVA, that it was initially at least very high prevalence areas that should be doing the testing. We're hoping that you guys in your study will come up with some conclusions about exactly where it makes most sense to sort of draw the line, and we will build on that essentially. So, I mean, obviously it would be a dream to be able to do it everywhere. We've got to make sure that we continue with the funding first, and we'll be using the evidence from the new programme, definitely in policy and advocacy spaces, to think about what the next case is. There's obviously nothing to stop individual hospitals from getting on with it if they want to in the meantime. Is that a fair assessment?
Yeah, I was going to just add. I was just going to add to that, you know, if you as a hospital feel that this is something that you should implement, it's about making a business, you know, at the moment it is just this, but it's about, you know, I used to be a HIV specialist nurse and we did it in Reading 10 years ago, and it's kind of about finding those things, but it's also about, not just about universal testing, but actually educating your staff so they're even just testing people who may have HIV indicator illnesses kind of coming up. So even if you're not testing, the education side that Sue and Chris are doing is really important, and actually that can start now, and increasing education across the hospital is really, really important.
Yeah, just to kind of add quickly, I guess, and just reflecting on what Kevin said this morning in terms of where we are in the epidemic and what we need to do moving forward, which is, you know, kind of, it would be brilliant to have, as Katie said, you know, this everywhere across the country and universal. If that is not possible, we need the right system in the right places to be able to get to 2030 and reach the people we're not reaching now and who haven't been reached through the process that we've got at the moment. So that will mean looking at different areas, looking at different populations and looking at that strategically in terms of have we got the right testing system in the broader kind of scope to meet the needs of where we are now in the goal to 2030 and ending transmission. So I think it's that strategic oversight needs to drive where the interventions and programmes are prioritised for the next round of funding if we aren't able to get to the perfect, which is all testing everywhere.
So Chris and I do this role on top of our own clinical work with our patient cohort. You know, so that can be quite difficult, but it's about finding the right people who want to be engaged with it, you know, and identifying those people. We have found one nurse in ED who's really, really sort of buys into it, and as I say, she makes sure everybody is given time on the off duty to attend, and if they don't attend, she wants to know why, because it's part of their, you know, rota for that week. And we've also made sure that we're visible on World AIDS Day, and we've done Hepatitis Day this year, where we actually go to the hospital in the mezzanine area, and we just have put boards up. We did a quiz, didn't we? We got 600 forms, and we're going to redo it this year, and it was scary to think just how many people didn't know the basics even of HIVs. But education is key, and certainly in your other areas like for HIV indicator illnesses, they're missed time and time again. I've just put in an untoward for a chap that was missed 7 times in specialities, you know, and it's trying to raise that awareness somehow.
Yeah, so that's exactly what I was going to highlight, is the fact that it's about education, because obviously people don't know what they don't know. So if, for instance, we'd like to saying on World AIDS Day, we do have a big presence in the hospital, and we were quite shocked because we did a stigma awareness survey just about how come into contact with HIV. Are you aware of even the testing happening in ED? And we actually thought the footfall that we thought we'd get would be the general public, but actually it wasn't. It was nursing, obviously healthcare assistants, and it was surprising. The knowledge wasn't there. There was a massive gap around HIV testing, even PrEP, the U=U message, all that information they didn't know the information. So part of that training isn't just about the ED projects, it's about the messages that we need to get across, how to access PrEP. And we do, as much as it is an extensive 2-hour session, it's got a lot of information in that, but then we always try and have that presence at World AIDS Day, and now we've linked in with the hepatitis, the liver service. We do have that. We are there to promote the messaging. Like Sue said, we are trying to because of the training we've put in place now, we are trying to obviously reassess that and see if there has been a change in the information, people's knowledge about testing and HIV. Yeah.
Say bribery works very well for healthcare professionals. We like a pen, we're very easily pleased, and we were pleased with the bag this morning as well. That was extra bonus. But we always bribe with pens and key rings and trolley tokens, and you'll get a lot of people at your stall.
One site bribes their ED with cake.
Just to follow on from what everyone else has said, obviously I think education is the main thing, but it's also about making that education accessible as well. So EDs are obviously really, really busy places. You know, taking time out for staff to go and train can be quite tricky as well. So you know, finding ways to make it accessible and you know, not saying to cut corners, but you know, in formats that make it you know, where you don't have to essentially take half a day off work to go and do that as well. So I think that's something that we've been quite keen to kind of explore going forward, just that, you know, how can we make training accessible and easy for people to digest going forward.
And part of sort of the wider rollout, I think that's why our national evaluation is really important, because the government's going to see they've invested this money, what they're getting for it. So part of us finding out, you know, how successful it is and actually how cost effective it is really important for the next steps. So, okay, thanks. Another question?
Hi, I'm from Hampshire Sexual Health, and we cover the whole of Hampshire and the Isle of Wight. We've got 3 EDs rolling out testing very soon, hopefully, and we very much support that. I've not seen much research into the impact on sexual health services who are doing the follow-up testing for HIV and the increase in our caseload of HIV positive patients that will result from this. I know it's very early days, so there's probably not much data there, but we'd really like to see some research into that to help us with costings and predicting the future caseload.
So our first evaluation was more based on the implementation, but we're now evaluating the next rollout, which we are going to be looking at that follow-up stage a lot more. Some of the things that came out of the public health evaluation was that the people who were engaged in care was lower than people who were tested through sexual health clinics. So I think that's something we really need to explore in more detail. Why is it? And it probably has a lot to do with, being in an ED, but then what extra supports do then we need to put in place? I know this is about HIV prevention, but one of the big things that came out of the first rollout was that Hep B cases were a lot higher than people expected, and so that has been an area that needs a lot more funding and a lot more put into it. So I think as it rolls on, this is something that we will evaluate further, and probably Sue can give you on the ground experience.
So for ourselves, we do test slightly different than everywhere else. We do our test from a separate tube, and it goes directly to virology to do the testing, rather than on the same sample as UNEs, simply because it gives a lot less false positive results. So we do get like an influx of false positives, and that is managed by the HIV team, simply because we are the area, so they don't go anywhere else. We get a handful of those, or a run of those, so it doesn't impact. But again, it's something that I have to pick up separately, other people that I work with, because Chris is based in Preston, so he doesn't actually get involved with the results in that respect, do you? So the positives ones that we do pick up in ED, obviously we just bring in straight away, as you would with any new positive. So you just make... I'm sorry, say that again. Yeah, well, so's ours. We've had an increase of over 40% and not, of HIV positive patients attending our sites, and no increase in staff whatsoever. It is appalling, because obviously it's not been reviewed for the last 20 years, and we are getting that increase. But at the end of the day, we just keep rolling with it. Hepatitis B, like we said, it's a national picture where they're picking up loads, and there's no clinics in place. And there's a doctor called Stuart Flanagan in there, who is looking at how we're going to set up clinics for that. But we're also trying to do that in Blackpool, aren't we? We're working closely with the liver service to try and set up a clinic. And also for the indeterminate or false positive results, we want to employ somebody to deal with those, because, well, it does take time, but that'll come out of the funding monies, so and may not attract somebody because it's not a long-term post,
One of our issues is because we've got these three separate trusts providing the emergency department services, and we're one trust providing the HIV specialist service. We've got to negotiate with each of those trusts for a slice of that funding, and that's proving challenging as well. So,
well, we didn't even get our funding. It went to Manchester, to the Integrated Care Board, and they hung on to it. Didn't even notice that they got it. We've had to beg it back, haven't we? Yeah, it's... Every little bit helps, and I mean standardising. We work with a good pathology team, because again we just have we don't have a joint path lab thing, do we? Did you want to speak, Chris?
I was just going to say the funding is because obviously we went from 26% of the total people who are attending A&E to 80%. So then the majority of the funding just becomes testing. So when you start to try and look at roles, like I know Manchester have like a tracker, results tracker, someone who will then chase the false positive, etc., which is an invaluable role, but unfortunately we just in Blackpool don't have that funding, because obviously the more testing you're going to do, yeah. But I'm sure that will come in the reviews.
Anybody else?
Okay, is there another question?
Did you get any funding towards peer support at all?
In what respect?
So have you got a peer support team? Did you get any funding to increase that?
No.
The new
Yeah.
rollout, the 10% is going to community. I still think funding is very, very tight, but the new rollout has got 10% going to community organisations. So funding is still extremely tight and only covers testing, but there is some funding.
Chris and I,
Yeah.
we're backfilled about half a day each to provide this, and it takes us far more time.
Yes. And so, you know, one site, their Hep C nurse goes down every morning to get...
That's awesome.
Oh, is it you?
It's awesome.
To me? Oh, well, then another site as well, though, does. They go down...
They're out every morning to check what's going on and see if the posters are up.
Yeah, and
Been ripped down overnight.
and also just to pick up the bloods from one pathology and to walk them to another lab, because they were getting lots of inconsistencies in that. So there's a lot of little things that has to happen. And Hep B in some sites have 9-month waiting lists. So I think it's really important, and the funding is so vital and it's really great, but we just have to make sure that we show that there is
a need.
Yeah.
Any other questions?
Hi, my name's Leon. I'm from Trade in Leicester. It's sort of a two-part question. What training, obviously when someone gets a reactive result, language can be really important in delivering them that. What training is given to any staff delivering that language, delivering that news outside of HIV services? And perfect timing, I think we're hoping for a slice of that 10%. To provide some peer-led support for people with new HIV diagnoses. So if there was one thing that you guys think would be useful for someone newly diagnosed with HIV, either through in-person experience or through this project in any way, what would that be?
To answer your first question, I can only speak for Blackpool, really. It's only the HIV team that manage those positive or reactive and false positive results. So the staff that work with me already have that knowledge base on how to give that information, because obviously it's a bit like cold calling. We've never met them, we're phoning them up, we're asking them to come in. And as for support and everything, we do the support, but we work very closely with Horizon, who have a counselling service and buddying service and everything else, that's singing and dancing, and going to be Revolution as well. So, you know, we work very closely with that, but that's just us. We're just lucky in Blackpool in that respect. Do you want? So, does that answer your first question, bit of it? Sorry, what was the second bit again? The slice. Oh, gosh. I don't know, Chris. Get your thinking cap on.
Well, I think one of the, and I think it's come in other talks with regards to having peer support in actual a clinical setting. We have our third sector, obviously, which is Renaissance Healthy Living. This is in the Preston site currently, but obviously having them actually inside, they have a clinic that is run by the support workers there, which is invaluable to us when, obviously, if I do get a new diagnosis within the clinic, I can literally refer them into the next room, because they, you know, they're actually on site and there's no waiting, there's no. But also, if someone's in crisis as well, it's again there's that support there. You know, so that I think that's invaluable going forward in the future.
I would agree, and I want that at Blackpool, but we've not got the room as yet.
Yeah, just on the answer the second question, if that's all right. I think one thing would be that's really kind of, I'd be hoping that we can kind of roll out and make a positive kind of change with is at the end of this year, the HIV Confident Charter Mark is going to kind of go beyond its pilot phase and into kind of a wider rollout. And I think every hospital where it's got an opt-out programme in place and in a high or very high prevalence area becomes HIV confident, because all of that stuff you were talking about, Siobhan, around the kind of the training, the people side, just that kind of awareness and knowledge, you know, it's great where hospitals are able to do that with ED stuff, but actually if the whole organisation, if that whole hospital, the trust, is able to kind of show that they are HIV confident and that people have got awareness, that we're challenging stigma, preconceptions, all of those things. So I think if we can align that kind of wider goal around awareness, knowledge, challenging stigma, and looking at, you know, the charter mark is not the only way we can do that, but it might be one way, to then go alongside the actual kind of mechanics of the opt-out testing, I think would be really impactful in terms of then making sure that the people are getting that right experience and the right support at the end of it.
Anyone, anything to add?
Okay. One very last quick question from us, couple. I was going to ask about the training you do. So it's a 2-hour training. So what's the uptake like of that?
They have to go, they don't have a choice.
It's mandatory.
Because they're actually, sorry, they have to go, the nursing staff. They don't have a choice, they're rostered onto it and it's part of the weekly roster. So they cover the, you know, so that's great for us and it works. Because some people, you know, just used to take a sly day off and just think, oh, I don't need to go to that.
Yeah.
But they have to actually sign in and prove that they've been. So that's good. And we're hoping to get in with the medics this autumn. But it's good, we get good feedback, we do evaluation, we try and change. But there hasn't been any sort of negative feedback on that. So we seem to have got it reasonably okay, but it's a lot to cover in a short space of time, and trying to make it impactful and meaningful to the staff and make it sort of alive for them as to see why it's so important, this project. So sometimes we sing and dance, Chris and I, don't we? You know, just try and make it fun.
Exactly, if it makes an impression. So, we can see from from
yeah, it
Siobhan's-
was a week like mine, just to confuse people.
We can see how important that training is, though. So if people,
assistants as well? Yeah, so they do with the nurses and the health
okay, I think it's time for lunch. So thanks everyone, fantastic session.
1 1 1 1 test test 1 1 test test. One test test.
Okay, welcome everybody. My name is Steve Worrell from Positive East, and I'd like to welcome my three colleagues who will be presenting their papers today. It's the after lunch slot, so please no snoring from the back if you do fall asleep, and if your colleague can actually just nudge you to keep you awake. What we'll be doing is all three papers will be presented, and there will be questions after that particular session. So the first person I'd like to introduce is Dr. Alison Brown from AXA. Alison is a consultant scientist in HIV and AIDS reporting section. She has a research interest in measuring levels of transmissible virus and monitoring programs to ending transmission of HIV. So what I'd like you to do is please give a big hand to everybody. In the question and answer sessions, please be kind. It's quite scary being up here for some people. And over to you, Alison.
Thanks very much. So as Steve says, my name is Alison Brown and I'm from the UK Health Security Agency, and I'm going to present today on how we measure people who are not retained in HIV care, how many people are not in care, and who are those people. So as all presentations, we start off with last time's action plan. So one of the key elements of the action plan published in 2020 was to improve retention and engagement in HIV care. And that it really is critical because of several reasons. So this graph here shows a number of people living with transmissible levels of virus. Some of these people are in care, but this is important because people who have transmissible levels of virus may be more likely to become ill, more likely to have higher levels of morbidity, but also can pass on HIV to sexual partners. Now, not all of these people are not retained in care. If you look at the top bar, you'll see the first portion of the bar graph are people who we estimate to be undiagnosed. The second portion, the darker blue and the lighter blue together, are people who are not linked to care after diagnosis, and those who are not retained in care. And that adds up to about 6,700 individuals. So what's important here is that we now have more people who have a diagnosed HIV infection but who are not retained in care than we do people who are living with undiagnosed infection. That means we need to invest as much energy into getting people back into care and sustained and supported to be in care as we do with HIV testing. And that's important not only to reduce morbidity and deaths, but also to reduce undiagnosed infection. Just for completeness, the other elements of people who are not have got transmissible levels of virus are people who are in care but not yet started treatment, and people who are treated but not yet supported to attain viral loads. So clearly, there's lots of work to be done across the spectrum. This year, we will, in our monitoring and evaluation framework, which will be published on the 1st of December, update these figures, and we'll also make sure that we integrate people who are not retained in care as part of the 95, 95, 95 metrics, and we'll show the impact of that. So this is how we measure non-retention in care. We have two different definitions. We send lists to clinics across the country of people who are not retained in care. That is, people who have not been seen for care for 12 calendar months. And we use that for practical purposes so that clinics can prioritise follow-up of people not seen for care who are not known to be seen in other clinics. At UK Health Security Agency, we were able to have able to link people across clinics so we can tell if somebody has moved across the country and you don't need to invest time in trying to follow up that individual. We're really focusing on people who have not known to be seen for care anywhere in the UK. For our surveillance definition, we use a period of 15 months, and that's because national guidelines suggest if you have HIV and you're well, you should be seen at least once per year. But because there is a bit of slippage, for instance, you may have last been seen in December 2019, and then again in January 2021, that's still roughly a year. So we're using the 15-month to make sure that we're not erroneously including people who are seen on average once a year. So here are the figures of people who are not retained in HIV care. These are people who have been diagnosed but not seen for at least 15 months. On the left-hand side of the graph, you can see that the numbers who are not retained in care increased during COVID and have not yet gone back to pre-COVID levels. Just as we're seeing in the headlines all the time about education, with people not being in schools, we're still seeing much higher levels of people not in HIV care than we did before COVID. And on the little yellow dots show the proportion of people who are not retained in care on the second y-axis. The right-hand side of the graph shows people who have not been in care for at least 5 years, but we're less certain of these data for two reasons. Firstly, these may be due to difficulties matching between patients. And secondly, we don't have information on people who have left the country other than our follow-up with the sites. So we're less confident on those. So we think by focusing on people not seen year on year, as a cohort going forwards, we'll be able to track progress and interventions to get people back into care. So roughly we have about 6,500 people who are not in care each year, and we have about 99,000 people living with a diagnosed HIV infection. This graph here shows it by the different exposure groups. It starts off with gay and bisexual men on the left, heterosexual men in the middle, and heterosexual women on the right-hand side. And what you can see is that the actual numbers not retained in care reflect the makeup of people living with a diagnosed HIV infection. So for the gay men, for instance, you'll see that the most people who are not retained in care are white, but you'll see slightly higher proportions of people who are not retained in care of other ethnic groups. And that's purely because of people living with diagnosed HIV infection who are gay men. Most people are white. For men reported to have sex with, for heterosexual men and heterosexual women, you'll see disproportionately Black African populations are the biggest group who are not retained in care each year. But you'll see a higher proportion in white other groups and white and other mixed groups. And we're going to do some further work digging down into looking at levels of deprivation, etc., to look at this in more detail. We're also able to look by country of birth and first place of diagnosis. So on the right-hand side, you can see here that there's a higher number of people, about 5,000 people, not retained in care who were born abroad, and a lower number of people who are born in the UK. Again, we aren't able to look at people who have left the country, so it might be that there are some biases there. The one thing that we do know for certain is that we do see higher rates of people not retained in care amongst younger people. And of people who are in care and on treatment, we know that levels of viral suppression are also much lower amongst younger people, people aged 15 to 25. So we see this with other chronic conditions as well, such as diabetes. We're hoping to unpick, dig down to the data to see whether these are people who have been born HIV positive and are possibly transitioning to adult care and need further support as they move from paediatric services, or whether look at some of the broader reasons behind it for this group. Obviously, it's a smaller group, but as a proportion, these groups are at higher risk of not being retained in care. So what do we do with these data? So twice a year, we send lists of people who have not been seen for care at any site for 12 months to each clinic. And that allows, and we take away people who have been seen in another clinic or those that have died. And this means that clinicians and healthcare workers can focus attention on trying to engage the people back into care. But clearly this is very time intensive, and also interventions to encourage people back into care need to be sustained. A temporary fix might mean you're back in care for 1 year, but some of the preliminary work does show that we need to keep on sustaining interventions such as trying to address some of the structural determinants such as being at work, not being able to afford it, childcare, etc., and other issues that we know are barriers to being in care. And our next steps are going to be looking at predictors of people who are not retained in care each year as well. I'm not going to go through this flow diagram because I always get confused, but I'm just going to talk through some of the key messages here. So of the around 7,000 people, 6,000 people who are not retained in care each year, we know that by about a year later, 50% come back. So these are not necessarily people who are permanently not in care. That could be due to the efforts of people trying to get people back into care. We also know that of the 50% of people who come back, a significant proportion of them are virally suppressed when they return to care. And that suggests to us there are not people who are actually not retained in care. Either there's not been recorded because they've been seen in online services and information hasn't flowed through to UK HSA on virtual attendances, for instance. So if we adjust for those people who are virally suppressed at apparent reattendance, the 7% of people not retained in care actually reduces to 5%. So we think about 5% of people are not retained in care. So that's the takeaway message. We are making that adjustment based on viral suppression when people do get seen back into care. And then looking at it from the flip side, of people who are then re-engaged in care a year later, we know that 63% of those, it is an effective re-engagement. And what that means is within 6 months of re-engagement, those individuals are virally suppressed again. And that's the definitions we're using. So we're using definitions for being not retained in care year on year. We're adjusting it to account for people who are virally suppressed at the time of re-engagement. And then we're looking at a measure of effective re-engagement, which is of people who are not retained in care, what proportion then went on to be virally suppressed within 6 months. So in conclusion, we have been exploring different ways to monitor non-retention in care because it's a public health priority. We now know there's more people not retained in care than there are people who are undiagnosed. And it's critical to reduce mortality and also to reduce onward transmission. The overall numbers have increased since COVID and have not returned to pre-COVID levels, which is particularly of concern. We know that younger people in particular and also white other groups and other mixed ethnicities are people who are apparently most at risk of not being retained in care. We also see a slightly higher burden amongst women than compared to other groups. We are continuing to support clinics and sending lists to each trust to focus retention in care. And we're developing these measures as part of our local care pathways, working with local authorities so that people can monitor retention in care at a local level and devise initiatives. But we have the tools now to be able to monitor the impact of interventions to get people back into care and meaningfully, effectively re-engaged. And then one final plea is, we can only measure this if we have accurate data. If we do have data missing, it will affect the numbers of our estimates of people who are not retained in care. So if you do work at the clinic, it really is beneficial to work with you. And thank you very much for your support and getting high quality data given to us promptly. And finally, I'd like to thank everybody in the HIV team, particularly Veronique Martin, who produced most of these slides and her analysis, and also all the people who provide us with data. Thank you very much.
Great, thank you, Alison. And I think a lot of information to think about and think about how we can apply it in the work we do. The next person who's going to speak is Dee Wang, and I've got some crib notes here about Dee, so please bear with me. Dee is the Deputy CEO of Spectra, where she leads the organisation's monitoring and evaluation efforts. She has over 20 years' experience in HIV prevention and has worked extensively with MSM, sex workers, and people living with HIV. Dee has, I know from experience, has a very strong background in data management, capacity building and communication, and has the advantage of also working with the Chinese National Centre for HIV Control on the Global AIDS Fund. So I look forward to this presentation, and Dee, thank you.
Thank you. What a wonderful introduction. I just made me feel better about myself. Thank you, everyone. Thanks for being here listening to me. And today we are going to delve into a crucial piece of work that the GMI partnership has done. So Spectra, Steve introduced me as a Spectra person, but actually Spectra is part of the GMI partnership. So this work is actually delivered and commissioned by GMI Partnership. So this work is focusing on the factors that influencing the disengagement and re-engagement in HIV healthcare, particularly within London's diverse communities. So this is a literature review, intend to provide insight to barriers and facilitators to continue care, especially in the context of HIV prevention and support services. So in case you don't know who GMI Partnerships is, bear with me if you know that already. So GMI Partnership is a London-based collaboration between 3 organizations, Positive East, Metro Charity, and Spectre. So we focus on sexual health and HIV prevention. We provide targeted outreach, education, and HIV testing and support services, so aiming to reduce HIV prevention and improve overall sexual health well-being. So I don't think I need to explain to you more about the importance about disengagement, why we need to tackle it. We all understand the impact of non-engagement as higher mortality and then mobility, increased HIV transmission, and overall public health implications. So considering all these factors or these impacts, GMI decided to do a piece of work and to look at factors which affect this disengagement from and re-engagement into HIV care. And so we hope that all this finding will subsequently used to shape treatment and healthcare. In late 2023, the partnership carried out these extensive reviews and to try to better understand the situation. And so the database searched, including PubMed, organizational websites, and government and the third sector's reports. So use the keywords like mentioning here, I'm not going to read them out. And this research yielded 27 studies, and that were all included in this review. And first, we want to focus on disengagement. So what are the factors leading to disengagement from care, and which group are more likely to disengage from care? So disengagement from HIV care is shaped by very complex and interplayed of factors. It's deeply entwined with people's identity and the social conditions, such as race, gender, sexuality, age, and then health status. So which we summarize them, categorize them into individual factors. So these individual factors significantly influence the individual's engagement with care. For example, like Alison actually mentioned earlier, we found that women in heterosexual community are more likely to disengage from care, and both sides of the age spectrum, both older and younger, are actually likely in higher risk of disengage from care. And so unfortunately, we don't have much data regarding the trans communities here, so that will be a gap that we will try to address in the future. And I need to highlight here, when we look at all these individual factors, we need to realize there's an intersectional identity characteristics. So one person doesn't just about their age, we're not just talking about their gender, they all connected with each other. So for example, like racially minoritized group, they face compound challenges. They experience not just health disparities and limited access to quality health care, but also there's additional layer of like stigma and discrimination, and this barrier often intersects with like social cultural factors such as cultural beliefs and the practice, which can further hinder access to care. And moreover, we look at social determinants of health. So these are conditions in which people live, work, and growth, as defined by the World Health Organizations. So this further complicates the engagement in care. Issues like poverty, migration, domestic violence, housing disability, instabilities, and the lack of education or community support can significantly impact the care continuity. So lastly, we look at treatment and care factors. So they add another layer of complexity. So those dealing with complicated treatment regimens or multiple medications might find it very challenging to stay stay engaged, especially if they've been diagnosed for a long time and then they are not achieving viral depression successfully. They're probably more likely to actually drop out from HIV care. So after engagement, we look at what is actually the key factors to helping people to re-engage back into care. So re-engaging people living with HIV care requires a multifaceted approach to address both social and health factors that we mentioned, healthcare factors that we mentioned earlier. So firstly, we look at social and community factors. So peer support, as mentioned by many studies we revealed, has proven to be highly effective in re-engaging people in HIV care. So by meeting people's need in a more holistic way, peer-led initiative provides a sense of community and a shared experience that can motivate individuals to return to care, and additionally, community-based testing options kind of provide testing options in a sort of a friendly and then a more supportive environments that help reduce barriers to re-engagement. And next, obviously, we've been highlighting this a lot in the whole conversation today, is we have treatment care and diagnosis factors in the health system. So the strategies such as like self-testing and opt-out testing in A&E departments, they're all making things easier for people. So they make people easier to re-enter the health pathway. And this method also reduce stigma and increase accessibility and make sort of a testing a more routine part of healthcare, which can encourage those who have disengaged from HIV care back into the service that they need. And there are also, we noticed that there are patient monitoring tools available now, like Alison was introducing to us, like clinical stewing, auditing, and recalling patients back to the clinics. That also helped to identify those who might be falling out of the care system and reach out proactively. So after all these factors, we also look into interventions, what intervention might actually help to, oh, sorry, I missed this key point. Yeah, how can I miss this one? So this is one of the last one, but actually the most important one probably is stigma. So stigma, whether it is sort of impersonalized, is perceived, or is enacted, it creates a huge barrier to people, for people living with HIV. So it can lead to fear of judgment, discriminations, and lead to social exclusion and discouraging individuals from seeking and continuing care. So stigma often intersects with other aspects of the person's identities, such as race, gender, and sexual orientation, so amplifying its impact. And after looking at these factors, we turn to interventions. So we want to find out what kind of interventions been told that works to retain people. So we have put all this, what we found, into a table here, and outlining various intervention strategies that addressing the factors we mentioned earlier. So it covers sort of reducing stigma through healthcare professional training, mental health support, combating poverty, addressing substance use, and culturally tailored intervention. The aim is to actually target specific groups, and including those experiencing like mental health issues, poverty, or racial minorities, or to improve overall care and support. And these interventions, that they are focusing to addressing those interconnected factors, which are essential for developing more comprehensive and equitable strategies to support those in need. Also, back to stigma again, and addressing stigma through education, awareness, and inclusive healthcare practice is essential to improving engagement in HIV care and ensure everyone feels safe and supported in accessing the service. Okay, so moving on, what actually lead people back into the service? So what helped in re-engaging? So this actually includes expanding testing options. Last time we pretty much covered earlier, and reducing stigma through targeted interventions and providing a peer support. So we focus on a collaborative approach with healthcare teams and then utilizing tools like the patient's reported outcome measures, prompts, and to improve patients' outcome and their support services. So by leveraging community support and improving access through strategic healthcare practice, we can create a more inclusive and supportive environments that encourage re-engagement back to care. So I'd also like to highlight some of the critical gaps that we've found, and then we want a future direction to engage our, that emerge from our review. So there is a pressing need for longitudinal studies. So what we found nowadays is quite variable, but they are snapshots of what's happened at the moment. So a deep understanding requires tracking the individual over a long term, and longitudinal research actually will help us to better understand the dynamics of disengagement and engagement, and identify patterns and assess a long-term effectiveness of the interventions. And secondly, we want to understand better about some very underrepresented populations, such as trans identities, people with trans identities, and those from diverse ethnic backgrounds, and individuals with like co-current conditions, and all those who living in a very limited, resource-limited setting. And addressing this in each gaps will actually ensure the intervention are inclusive and effective across all segments. So lastly, again, multidisciplinary approach is crucial, and it is inherently complex and multifaceted. So there's lack of sort of a study looking into a combine of medical, psychological, social, or economic, sort of all multidisciplinary research into data that we actually would like to see. So these are the gaps and then the future directions that will be helpful. To conclude, so first I'm giving you the list that we found out. These are the groups are more likely to disengage from care, from the finding from the reviews we've found. And so we do want people to realize that although we're giving you a list of people who are more likely to disengage, but we want to highlight the significant shifts from the traditional binary view of a patient being sort of engaged or disengaged from HIV care. Instead, it's actually in sort of a nuanced perspective. Like, we need to recognize patients' engagement exists on a continuum. So this continuum knowledge, engaged care, means that this is not a static status. People can actually get in and out of the care. It's a very dynamic process that can vary over time. So understanding this continuum is crucial when we design and then implement our services or interventions. So we need to move beyond a one-size-fits-all sort of solutions instead of tailor our approach to address the diverse and evolving needs of our people who live with HIV. So our review also identifies several barriers to engaging in HIV care and support. And they are complex and then multifaceted, so ranging from structural challenges, such as accessing healthcare facilities, to personal factors, including stigma and mental health issues. And addressing these barriers requires a very comprehensive understanding of the factors that's actually contributing to disengagement. And moreover, the intervention aimed at retaining individuals in HIV care must be tailored to meet the need of a diverse and intersectional populations. This means taking into account of various social, economic, and cultural factors that influence the individual's ability to stay engaged in care. So again, a multidisciplinary approach is essential for effective intervention and collaborations across different sectors, including healthcare providers, social services, and community organizations, will ensure the strategy are holistic and address the broader spectrum of factors. So thank you. And if you're interested with the full report, that QR code you can scan, and once you get hold of this PPT, you can click on the link straight away. And thanks for all the authors of this piece of research. And If you have any questions, feel free to contact us here. Thank you.
Thanks, Steve, for that. I think in the conclusions, there's probably quite a few questions that could potentially be asked. And also a big thank you for Dee. I don't know about you, but sometimes the papers that are produced are a bit overwhelming with just pure statistics and everything else. And it's nice to see something distilled in a different way. The third speaker is Gary Brough from Fast Track Cities London. Some of you might know Gary in a different guise, having worked in the voluntary sector for the last 25 years. Gary has actually been living with HIV for 33 years, and the main focus of his work is about increasing peer support in different locations. So the presentation is about looking at the key elements of the 2020-2023, he says, falling over his words, Fast Track Cities Improvement Collaborative. So thank you, Gary.
Thanks, Steve, and thank you for your work in delivering the programme at Positive East on this. So I'm speaking on behalf of Fast Track Cities London as the programme manager for the current round of programmes. But for this presentation, I was also the lead at Positive UK for the work that we did at Chelsea and Westminster. So I'm wearing two hats, which is not unusual for me. We've heard the information around what the data is and what the approaches could be, and this programme really looked to think about what the solutions could be on a practical level. So in 2020, Fast Track Cities London funded a range of improvement collaborative projects to work across HIV from prevention testing onto post-diagnosis support, and it really brought together a range of community organisations to work in partnership and to pilot and try out quality improvement methodology to look at better practice and better results. And so the focus of this presentation is 3 specific projects which are delivered by Positive East, Positive UK and Metro with their local clinics, HIV clinics, to integrate peer support within the clinical pathway and to think about the different approaches that were needed around engagement in care. So what was done with each of the projects was slightly different aims, with the idea that you didn't want to have everyone just looking at the same thing. We want to be able to compare and contrast. So in North East London, through Positive East, there was the implementation of wellbeing assessments and inclusion within the MDT to look at whether there were a better identification of unmet needs and, you know, those wider determinants of health that result in people dropping out of care. And then what that could do to then make the referral into the additional support that would then hopefully deal with those issues and support people to stay engaged in care. In South East London, Metro provided a re-engagement in care option. And so they had a peer support worker that worked with individuals around individually tailored support programs to deal with the challenges that they were experiencing that had resulted in them dropping out of care, and then support them to achieve an undetectable viral load, but also to deal with those determinants of health by referral back into the voluntary sector support. And then the third one was for North West London with Child West Clinics, was Positively UK, where we were implementing peer support workers in the clinic and looking at what the pathways were to accessing support, to try and shorten the journey that people had to go to access peer support, to be able to have peer support workers in the MDT, and then to make those referrals into the ongoing support that was needed when issues were identified. And so really all of them relate to wider determinants of health. But what I would flag up here is that that's not just benefits, immigration, housing, nutrition. Primarily, and this is what we've seen from some of the research that's been done in South East London, one of the main issues for people dropping out of care is stigma. It's already been addressed here. And if you don't deal with the stigma first, then all of those other things become just an increasing and compounded impact. So at the point of diagnosis, at points of crisis, or at re-engagement in care, that peer-delivered perspective is what challenges stigma most effectively, we believe. And I'm hoping that the evidence that we have by the end of this next round will demonstrate it conclusively. But it has been shown to be effective in the programs that I'll show you now. So in relation to the results of what was delivered, Positive East, and they work with BARTS and Barking, supported, I'm going to need my glasses. Yeah, oh no. Oh, there you go, that's better. The angle is terrible for that one. So they supported over 480 people. And what they saw as a result of that collaboration within the clinic, compared to what the normal referral pathway was, it was a 68% increase into the voluntary sector. So that's 68% of people that actually those needs would not have been identified if the peer support worker hadn't been there and if they weren't undertaking those assessments. The other thing to say with this is that lots of people are talking about PROMs and this very, very slow implementation of PROMs, patient-rated outcome measures. What's been done with this and with the tool that we're currently developing is looking at PROMs and saying, PROMs are great. They're great for a snapshot every year as to where people are at. But what we're trying to consider is crisis management here. And therefore, we need to have a more detailed and a more structured assessment that looks at unmet needs. And so that's what was done with this project. The Gilead Wellbeing Thermometer was adapted to consider more wide psychosocial issues than just the medical nature of things. So when you look at then what happened as a result of those referrals, there was 60% of those that were referred in received additional emotional support, and there was a partnership with Living Well for their Connect Well services for anyone living in London. That was part of the programme. Housing outcomes improved for 35%, and for anybody that's had to try and deal with housing, you'll know that although that's only a third of people, that's nothing short of miraculous, because it's a really, really tough one. And financial outcomes improved for 69%. And so when you think of nearly 70% of the people that were supported having a greater financial stability, the potential then to maintain that engagement and care is massively increased. In fact, I'll throw in another stat from the Positive UK project that was done alongside this. They secured over £2 million worth of benefits for the people over a three-year period. And that's people that had been trying to get benefits, couldn't get it, but with the support of a professional advisor, were able to then secure that. And what I would say is that for a large number of those people, and for the people seen in these programs, they weren't necessarily British born, English was not necessarily their first language, and anybody that's had to deal with these systems knows that they are there to put people off and to make it really difficult to get your needs met. So, the results from Metro, so this was the re-engagement in care project. So there was targeted support for over 100 people with complex needs. 60% of those were forwarded on and into the voluntary sector for additional support. Out of those people, 85% achieved an undetectable viral load within the course of those here within 2 years. And when you think about the challenges that we see and people, as I say, disengaging and re-engaging, sometimes within a year, the difficulties that were addressed here were multiple. Stigma was clearly one of the primary ones. Again, there were a large number of people that weren't necessarily British born. When they were white gay men, there tended to be issues around drug and alcohol. And so the pathways then into that ongoing support through the voluntary sector were key in relation to the successes that we saw from it. And what we then saw, just as a result of this, so although we were looking specifically at this group, as an additional benefit, the fact of having the peer support worker in the clinic and as part of the MDT resulted in over 200 additional referrals into the voluntary sector for unmet needs and issues that were going to be able to be supported by the voluntary sector. The point that I'd make when it comes back to PROMs and the fact that very few of us living with HIV have ever filled in a PROM is my belief is that part of the rationale and the challenge in implementing PROMs by the clinical teams is a lack of resource to be able to meet and address those unmet needs. And so this approach of having voluntary sector workers paid and integrated within the clinic means that that support is available and you can ask those questions with the knowledge that you can make the difference that's needed. And so last but not least, the Positive UK, in partnership with Plus Health, NAS and Chelsea and Westminster clinics, we supported nearly 300 people, and with 2/3 of those being referred again into voluntary sector support. We implemented an in-house e-referral pathway. So being part of the MDT makes a difference, but not having to go to an external organisation makes a huge difference. So just having peer support at chelwest.nhs increased our referrals 12-fold. And that happened within the first kind of 6 months. When we look at the referrals for peer support, so it frustrates me still because I'm still seeing it in other clinics. What happens is when somebody's diagnosed and they have that first appointment with a doctor or a nurse or a health advisor, and they say, oh, and would you like to speak to a peer support worker? A, does the doctor or nurse know what that means? B, do the people just diagnosed know what that means? And C, when you're in that state of crisis and just having that first appointment, are you in a place where you can even conceive of wanting to talk to somebody else? The answer to all three of those questions is often no. And so what we said was, okay, we've got these ideas as to what we do. Oh, no, let's do what we've done first. So for 3 months, we did it as they wanted us to, and we put a peer support worker referral pathway in. And what we saw was 1 in 10 of those people that were diagnosed took up support. We said, okay, you need to change now. How about we do opt-out? And you give us that 3 months of the list that you have now, and our peer support workers will give them a call and offer them peer support and explain what they do. And what we saw with that call over those 3 months, 1/3 of people said, yes, I would. I'd like to talk to you. That would be great. So we said, okay, that's a great improvement. Now, what we think is, and what we saw from that, the longer you've left it, the less likely people are to take up that support. So let's do this on a weekly basis. You give us that list of your newly diagnosed patients for the week. We'll give them a call. And what do you see? 67% of people say, yes, I'd like the support. And actually, the majority of the 33% that didn't were people we couldn't reach by telephone. And so the idea about having an MDT where you have a peer support worker is great, and it really makes a difference. But if you don't have a peer support worker as part of that newly diagnosed appointment, you're missing a huge opportunity to address stigma, to deal with those unanswered questions, because with the best will in the world, when a patient is talking to a doctor or a nurse, their anxieties, the fact that they can't really adjust to their own diagnosis, it's much easier to ask somebody else that lives with HIV about that. So they were some of the recommendations we have moving forwards into the next round. So basically, we feel that peer support is the missing piece of the jigsaw when you're talking about whole person care. The medical side, and we all know that when you look at health and well-being, medical issues only account for 20%. 80% is wider social determinants of health. And so having delivered these 3 years of programs, what we've now got in place and what I'm managing in the Getting to Zero program is a program to integrate peer support workers in every London clinic. What we then also fund is the voluntary sector backup support on all those issues that have already been identified, so that we have the pathway straight from the clinic into the voluntary sector as a joined up program between the collaborating organisations, and so it becomes a genuinely pan-London approach, and looks then to be able to assess and monitor the improvements in well-being, quality of life, and hopefully stigma reductions as well. And there's a quote there from somebody who was through the re-engagement in care program, and that fact, that somebody would be battling mental health on their own for years without knowing how to ask for help, to be offered that by somebody that understands that has walked the walk in your shoes makes such a difference. So I'd like to thank the team that delivered this across the 3 clinics. The clinical leads who supported the work, and if you're interested, you can see the various programs and reports on the Fast Track Cities website, and thank you.
Great, thank you, Gary, and more rich information for us to think about this afternoon. I'd like to say thank you to the 3 speakers for being up here. It's a scary time for people. Now it's even more scary for them because it's question and answers. What I'd like to say is please be kind in your questions. There's probably a lot. I'm going to stand up here so I can see the whole room and point to people. But any questions, please raise your hand. Yes, this lady here. There should be a roving mic somewhere, hopefully. No, you need that. There we go. I'm like Gary, I can't see without my glasses.
Hi, I'm Jo Copping from Bristol, consultant in public health. We have a fair bit of peer support in Bristol. What I haven't heard much about is at the conference this time round is around funding. So Fast Track Cities, London, is a slightly different. You do have a budget, whereas other cities don't have the same sort of budget. Who do you think should be responsible for funding that peer support within clinics, as you talk about?
Who do I think should? The ICBs. It should be part now of the MDT. The rationale for us doing this implementation through getting to zero of peer support in every clinic is we have allocated a specific amount of funding per ICB, and that makes no difference as to how many clinics there are, because we have a lot of clinics in London. And what we're going to do is look at how much was spent by us, how much came in to provide peer support as part of the opt-out testing, how much was also linked in via potential funding through local authorities, and what that delivers. So if we can provide the ICBs with this is the cost per ICB for peer support in all the clinics as part of what you're going to be funding for HIV treatment and care, bearing in mind that a peer support worker is generally around a band 4, so, you know, not the most expensive part of the team by any means, and the fact that, you know, one disengagement from care and admission into hospital saves the NHS £100,000. You put those figures together and say that, you know, so for every person that is retained in care and doesn't drop out, you've funded 3 full-time peer support workers, basically. And so what we want to do is that over the course of this next 18 months, well, about 15 months that we've got left, is to be able to make that case to say, this is the standard of care, this is what BEVA recommends, this is what the CRG have recommended in their service specification, this is what we know it costs, this is what we think you should be providing, and maybe what we've done is not quite enough, or maybe it is, and we can make that call. But this is now what you need to fund as business as usual. So don't give the money to Fast Track Cities. Give it directly to those voluntary sector organisations as part of that MDT that you're going to fund for HIV care and treatment. And so if we can make the case effectively in London, that should be the case that for anywhere in the UK. Clearly, the devolved nations will have to have their own arguments with their own services. But I would hope, especially as we work across Fast Track Cities and between, that we can make the case together for it.
Can I just clarify? So you're saying the ICBs, because the ICBs are taking delegated treatment, so that delegation hasn't happened everywhere yet.
No, in London, it starts from next April, and so
yes,
we want to be ready for it, to be able to say, you're about to commission, this is what you do. If you're not ready to do that, give us some more money, we'll continue it for a year until you're ready, but we've got the case and we can show you effectiveness already.
Yeah, I would agree with you. Yeah, it'd be good if we could have a whole-scale approach on that one. And
Great, thank you. Other questions from the audience?
Just before that, I'd like to give a shout-out to the Evolving Care report by Fast Track Cities London, which was, it's 2 years old now, but it maps out what the priorities were and gives the answers to the ICB, so follow that up.
Great, thank you, Mel. Other questions, anybody? Yes, and then over there. Okay, the lady in blue first.
Mine is just a comment, really. So I'm doing work on the opt-out testing. We're doing the qualitative evaluation of opt-out testing in EDs. And interestingly, I was speaking to a community organisation who said that they're getting very few referrals from the ED. So they work somewhere. So it's just interesting and something we need to keep an eye on, that people who are being diagnosed in ED aren't getting either referred or not thinking that they need peer support. And I think having someone in clinic would make a big difference for that. And so it's just a comment, really.
So certainly when they did the first round for the very high prevalence areas, one of the things that you look at in relation to the treatment and care cascade is that, you know, the testing or being retested, being referred into care, being engaged in care, being started on treatment, being offered peer support, it really drops out, which is why actually now when we went from very high to high prevalence areas, the wonderful Ian Jackson, give us a wave, basically went from a recommendation for providing that funding to making it a stipulation within the contract that this 10% of this money has to go to post-diagnosis support. And so I think it's about both those things. It's about making sure that the pathway is as short and as easy as possible with as few barriers, and that it works for the newly diagnosed, for those re-engaged, but with the understanding is that if you've got small numbers, then use that money to look at those with complex needs who may be at risk of disengagement, because prevention is always going to be better than cure.
Great. Thank you. This gentleman and then this...
My question goes to, is counseling, is it part of the intervention used? Because presently, I found out that counseling is no more making meaningful, it's not as pronounced as when HIV is at higher level. Are we using the impact of counseling the new diagnosis now? Because counseling is still a main focus to reduce the impact of self-stigma and stigma associated to HIV. Thank you.
So yes. So in relation to the peer support offer, that includes a degree of training around health coaching, so that there's the understanding about how you engage with people around their health and well-being. But separately within both the 20 to 23 program and in the current Getting to Zero, we funded Living Well to deliver counselling, coaching, and support groups as part of that around well-being and mental health, because the recognition is that peer support will do a lot of that, and we see in clinics where people are being referred to peer support and to psychological support. Often, that engagement with the peer support worker, they come in when they say, I don't need psychology now, I feel much better. And so I'm not saying peer support is the cure-all, although it was pretty good for me. But you need to then think about what the needs are, and clearly there are significant mental health issues along with the HIV diagnosis. And so that need for somewhere like Living Well, the focus that they have on counselling, therapy, and coaching is a really key one. So yeah, we fund that as part of this programme.
Thank you.
Well, whilst the mic is moving over, just a quick question for Alison. Going through your presentation, a question that often comes up is, do we have an accurate understanding of the number of people actually who have disengaged with care, or have we overcalculated it or undercalculated it? It comes up from time to time, and I'm just wondering if you would be able to comment on that.
It's not an easy thing to do. There's people who are not engaged in care for a multitude of reasons, and that kind of enacts itself in reality in many different ways. People come in and out of periods of their life, whether complex needs, difficulties, etc. So it's a very difficult thing to measure. What we've tried to focus on is people who we've looked at guidelines and tried to centre on what proportion of people are not seen at least on average once a year, which is the guidelines. We are confident in that because we're able to match accurately, and we do follow up with clinics to see if people have left the country. When it comes to longer term, we are less confident because the reliability of the matching is less good, and it's more likely people may have left the country. We also audit the lists that come back to us, and it does seem to be reliable. So, yeah, we are relatively confident about it, but there are obviously, we can't capture all the nuances. There's many reasons why people are not retained in care, and we need to make sure the systems are flexible enough to be able to measure that.
Great, thank you.
I'm still holding onto the mic,
okay.
I'm sorry. Because I just wanted to answer about counselling, because, I mean, we got from that presentation that it was stigma still was the big thing, and a lot of people referred to what was IAPS and is now talking therapy within the NHS were experiencing stigma. So there's a really good training that I'd like to direct people to that's available for all counsellors. So if you're doing IAPS, look at it. It's called Open Door or Bridge 2, I can't remember, but look at it, and there's training for your talking therapy counsellors to be HIV aware so that we reduce that stigma. Now I will pass.
Thank you. Thank you all for your presentations. A question both for Gary and for Dee. I wondered if there was anything that either you've seen in the clinic work or in the literature review around like training or upskilling when we're bringing the peer support workers in. Like basically, how can we make sure that the people we're bringing in are well prepared to do the job and then are able to make sure that it's a sustainable program, if that makes sense?
Well, it's an interesting question. Thank you, Haley. I can't really say that the literature review covers that much details, and I think one of the vital piece of evidence we found there is actually on Gary's report, probably. I think what we notice is lots of people saying the disengagement is due to sort of a lack of sympathetic approach from the healthcare providers, and then the stigma they feel when they interact with healthcare provider. So I guess that in another way proves to you that there is still a lot of work we need to do to actually sort of reduce stigma among the healthcare teams, and then maybe especially make a wider sort of a spectrum sort of education, because we are seeing that from not just GPs or pharmacies. We also talk about healthcare facility, nurseries, things like that. So this is a really wider sort of a picture of all health providers. That I think that is what has been seen in the literature review.
So in relation to the peer mentor training, so the peer support worker, peer navigator, there's lots of different terms depending on where you are in the city, in the country, and sometimes within a borough as to what they prefer to say. But peer support workers undertake the Project 100 training, so that's what I joined Positive UK to deliver, and it's an accredited national training. Put it this way, what we've delivered in the second round is additional social prescribing training, because we recognize that social prescribing is one of those key elements of the work that is identified and prioritized by the NHS, but that we don't do in HIV, or do we? Yes. Because actually when we passed on the peer mentor training to the social prescribing lead for London and said, look, this is what we do, can you augment this with what you need for social prescribing? And he said, no, because you do more than we do in social prescribing around this communication skills, the engagement, the pieces around health coaching that's in there. So your training is actually better than the current standard of social prescribing training. So one of the things I'd say is that the barriers in the past to this work and to the work in clinics has been a mistrust from healthcare professionals of the professionalism of the patients, because we are still patients, even though we are working involved volunteering as peer supporters, we're still patients, whose qualification is having got an infection. And I think that's the challenge. It's about changing that mindset. So when I talk to doctors and I defer to the fact that they have years of training experience, I do also mention the fact that I've lived with HIV for 33 years now, and so I have a pretty good understanding of it, and adherence to medication and engagement in care and what my needs are. And so the recognition that it needs to be both of those things. So the BEVA standards in 2013 said that peer support was essential, but it recommended recruitment, training, supervision, compensation for that work where possible. And so that when Project 100 was launched and we started to do that, by the time it got to the 2018 standards, instead of one quality statement, there were 7 auditable outcomes out of the 8 standards of care for peer support. And I think that shift was because of the fact that we recognized the need and we delivered a way of professionalizing peer support. Because you need to be able to demonstrate that you're trustworthy, that you're going to be delivering quality support. And then, obviously, as part of this program, that you get an honorary contract, that you get the training that's delivered in the trust around confidentiality, GDPR, with any other staff member. And that, again, that you pay it, that you recognize this as an integral part of the team. That starts to change hearts and minds a little bit, despite the fact that we still see gatekeeping. But then, obviously, the other work that Fast Track Cities London are doing are providing that training through the HIV Confident Charter to ensure that the other healthcare providers also have a better understanding. So you have the bottom-up approach, you have the top-down approach, and then you have that work within the MDTs, which hopefully changes things as well. And I think really for HIV, it has always been the case that combination is what works, and that you can't just have one thing to fix it. So you've got to come at it from every angle.
We've got time for one last question, and somebody over there has been waving at me for a while. So as Mel sprints across the room, doing her Olympic bit, the lady just there.
Thank you very much. My question is, my name is Stephanie. I am the Health and Wellbeing Officer for Caribbean and African Health Network. So my question is about the peer support. I hear so many questions and responses around it, and I think that's just one approach. And you said most of the peer support are in the clinics. So the question is, I do a lot of community engagements, and sometimes you get some new HIV new cases, and some of them don't have access to sexual health clinic. I've met some people who have been in the country for 5 years and have never been to sexual health clinic. So how do they get that support? And sometimes they give some wrong information in the process of testing because they are not too sure of where their information will be passed on. So how do you trace those cases? And I've also worked with students who come into the country, and some of them have been HIV positive in different countries before they came, and they don't have that support. So how can they get the support?
Okay, that's a huge question. We probably could be here all afternoon. A brief response?
Yeah, that is a huge question. I think if somebody is diagnosed and they're linked in, not just to the medical support, but to the wider voluntary sector support, that for me is where you get the best bang for your buck in relation to that ongoing engagement. In relation to complex needs, disengagement from care, as a result of that first round of Positive East work, for example, the fact that now they come to Positive East in advance of the MDT around those patients that they're about to be seeing to check whether there's pre-existing knowledge of them, whether they already have relationships, whether that might be a way into those things. And so I think the nature of what the work is that's being done, the collaborative partnership between all of our voluntary sector organizations and then between the voluntary sector and the clinic, having those multiple touch points and engagement points gives you a much, much better chance of success than making it the expectation that at some point they'll go to a sexual health service, because it needs to be different approaches and different entry points. Some people are more likely to go to community, some people will go to the HIV service, but you need to link them together if you're going to really make sure that you catch those people who may fall through the cracks.
May I just add something on top of what Gary is saying? I think when we talk about peer support, it's not just simply someone with living experience to talk to another person. Peer support itself is actually multidisciplinary, and then you need lots of sort of pathway behind you. So you can talk to people. There'll be housing, finance. There's lots of different aspects, immigration. So it's not just simply, so, oh, we're going to support peer support. You have to have lots of other things in your plate that you can actually offer to the person you're trying to support.
Yeah. So we need to just pull it together, coming to the end of the session. But I think what we've heard today is what's happening with the data? Do we understand the data, and what do we do with the data? What does the research actually show us? We know the factors, the research is there, but how do we take the research forward, and actually how do we implement it? And as Gary has demonstrated, there are different models in place where we can actually implement it to re-engage people, help prevent disengagement. But what this actually means is probably a challenge to our practice, a challenge to the way we are sometimes working in clinics and in the community. And what I'd like to do is say a big thank you to Alison, a big thank you to Dee, and a big thank you to Gary for their presentations this afternoon. I've learned a lot. I know that they've put a lot of time and effort into this, so a big round of applause for everybody. We finished about 3 or 4 minutes early than we were due to, so it's tea break, and then it's back to the next session. Thank you, everybody.
Specifically for NHS, so if you're employed by the NHS, which most physiotherapists are, There's, because I'm sorry, I should know what it means. But they had one specifically for other conditions as well. So it was nice that HIV was included in it. I can't think what the others were now. No, and that's why I say it, because it's and anyone who's accessing counselling now, I say make sure your therapist has accessed this training. It's very simple training. It's got a nice video featuring me, which is which just sort of explains, these are the issues. Don't come at us with judgment. Hello.
I need to kick these guys off this stage soon.
Give me 2 seconds and I'll find out the name for it. Yeah, no problem.
We now want to set up for the final plenary, so we're going to have 7 people. 8 people.
I've had 2 coffees brain and I'm just whizzing all over the place, as you can see. But I don't know.
Okay,
So say
brilliant.
again, sorry, I just did slide trust and I was like, oh, hello. And then and they can see it as an event, and they can see if you have a social gathering once every month, whatever it is, and they can then access it. Yeah. So, but what I need is someone who's to come onto the forum and put it on. Okay.
Do you have to turn it down, or can I just pick up?
Yeah. So that's my.
We had some more speakers and they remain on stage. There were more than 4 people, so they remain on stage. You can put it on.
Well, if there's 8 people up there, I doubt it.
Yeah, there are no slides, so just a
Well, yeah.
can't do that, can you? It's always like, do they record this?
In the clinic, whether it be like an advisor like you or a navigator like Ben, it proves the work of what we do in a way that like reduces the skepticism and increases the engagement for clinicians, which means they're much more likely to connect patients to us.
Give me a mic, I get carried away.
Your name is
We're up there.
So I'll take the board there. Maria.
from a candidate testing. You can do the testing, yeah, and then after that, I'll put the support. If you wish to show you the change, you just talk to whoever it is, right? And you can go to the candidate testing. You can do both if you want. But I will speak to that and yeah.
Do you know the people who...
So you're miking the speakers, yeah? Lovely. I'll go and grab them.
Yes.
Take care. Bye-bye. Ah, fine, yeah. Thank you. Does he want me to come out?
No, you're no. We need miking up.
If you can give me a hand, everyone.
Online we have 100 persons. Yes, no, we haven't. So, yes.
Can I put it on the other side?
Thank you.
How are you doing? You okay?
Okay, can you bring them here?
You do? Good.
Should be okay.
Really has. Thank you.
Oh, very sweet.
Oh my goodness. Oh my goodness, what's happening? Let's do it.
It's also a thing you can only really go to on your own. That's the thing about it. It's like, it's that thing.
Put that there as well. Yep.
Sure.
Thank you.
Well, yes. Hey, yeah. How you doing? Hello, Christy.
Pocket, is that any good? Or I'm not wearing a belt, but I have belt straps. Or, yeah.
Hello. Oh.
It's very professional. I'm used to just holding a handheld mic that I'm never sure is working or not. That's great, thank you. Beautiful. Thank you very much.
Just leave it here.
We haven't met before either. Hello, nice to see you. How you doing?
You're not going to leave it outside, then it will interfere with the mic.
I'll put it in my
And you're placing a glass, aren't you?
Thank you.
Nice, lovely. Great. Very good.
Can I take this off?
Yes, and maybe put it in the bag.
Have you been mic'd up? You've been mic'd up. Right, if you go to that end, you'll get mic'd up. Sinead, have you been mic'd up? If you want to go to that end. Adam, you need miking up.
Great, thank you. Ready.
Bloody. Got it. Good.
That's fine.
Anything else you need me to say?
End up wittering away in a corner. I think he'll grab you. No, you can't.
Which is broader is around the social determinants. That's the context in which people are experiencing their lives is quite diverse. So we need to just
Gosh, give me a hug.
all this
Lovely
trying to
to see you.
understand.
You got a pen?
It's so great to meet you. Exciting. So nice they let us out of the teams like universe. So it's great to be here. How's the day been?
Yes, we've been good. Really interesting, especially last session I was in. There was a group from
Cool.
where I live.
Fantastic.
Really good example of how
That's so important. I mean, that's where this has to go.
Yeah,
it's not
good.
just about the ultra high prevalence areas. It's about the rest of the country.
So,
Lovely.
I've got some specific prompt questions. Basically, I'm just going to ask what you personally are going
I
to
might
do.
keep it just in
Well,
case.
today I've actually just got to it.
I'm
So I
not
did
picking on you. I'm not.
with Steve. So we did the
thank you very much for still being here. We're going to keep you, well, ideally awake is my brief, so keep you awake and hopefully keep you a bit inspired. We've got this terrific panel of speakers talking about how we're going to get to the 2030 goals and what we think we need to do to get there. So I will start with some introductions. So man on my extreme left there, well, he's not on my extreme left, sort of moderate left, is Richard Angel, who became the Chief Executive of the Terence Higgins Trust in March 2023, and requires no real introduction to everyone else in this room, so I'll keep it fairly brief, if that's okay. But I think we should all thank Richard for putting on this fantastic day today. Moving along, we've got Adam Winter, who is absolutely key at the Department of Health and Social Care and was absolutely instrumental in getting the first HIV plan over the line and delivering that so we can have a second HIV plan, which we've been talking about today. So welcome to Adam. James Walgart is the current SRH and HIV commissioning lead in Liverpool and chair of the English HIV and Sexual Health Commissioners Group at national level. So that group feeds into the voice of local authority leads in national policy and aims to support local leads with best practice examples. James is also the chair of Fast Track Cities Partnership in Liverpool. So welcome to that. I'm afraid I'm going to have to use my notes because I don't know everyone all that well. So we've got Professor Claudia Escort, who is...
Shall I do it?
From back, you could do it if you like, yeah. So, yes, you could do it, actually, yes.
Good
I seem to have not been given a
everyone.
bio.
I'm Professor of Sexual Health and HIV in Glasgow. I also work in London, and I'm representing BASH today.
Thank you. Oh, I should never work with bits of paper. Let's go down to Christina on the end there. So Christina is the Senior Policy Officer at NAS, a sexual health and HIV charity that's a member of the One Voice Network, and you'll hear from One Voice Network today. Her work focuses on developing practical interventions to address health disparities rooted in structural racism and discrimination. So that's Christina Ganatakis. Sinead Ward is from Vive UK and is the General Manager. Started her career in the pharmaceutical industry nearly 19 years ago. She worked for multiple companies, including GSK, Novartis, and AbbVie, in diverse leadership roles and in diverse therapy areas, including diabetes, oncology, and most recently HIV, and is now the General Manager for Vive UK. And then we have Rachel Hill-Tout, who I've deliberately left last because Rachel has the misfortune to have to work with me all the time. And Rachel is has so many jobs that even I lose track sometimes. So Rachel's an HIV consultant and now GP as well, and is the national lead clinically for the opt-out testing programme in England. So it's Rachel. And I should probably say who I am for as well. So I'm Ian Jackson. I'm the national advisor to the opt-out testing programme. I sit on Fast Track Cities London, and I'm a contracts and planning director in my slightly more boring job in specialised important topic of how do we get to 2030, what we're going to need to do. So what I'm going to do is go through the panel in turn, and I'm going to start with Christine. And I'm going to ask, what is it you think we need to do to get to our 2030 goals? And I'm going to give everyone a couple of minutes just to talk about that, and then I want a particular focus at the end on what you think you can do as an individual, which might or might not be related to what you're telling us about what we need to do collectively. And as we go through that, I'd really like everyone to get an idea of the sense of there is enormous power in this room. There's quite a lot of power on the stage, but every single person in here is here because they've got some power in our fight in getting to 2030. And I really want to focus on not just what organisationally we could do, but what we can do as individuals to help us get there. So everyone to go first. But Christine, I'll hand over to you.
Thank you very much. It's really wonderful to be here with you all. So for those of you that aren't aware of what One Voice Network does, we're an independent collaborative of 12 Black-led organizations focusing on HIV care and support for Black communities across the UK. And there are 4 things that I want all of us to think about as we work towards a 2030 goal. And so the first thing is to act on the data. Across the social determinants, Black, African, and Caribbean communities in the UK have the poorest outcomes. This is nothing new. If you look at a UK HSA epidemiology report, the numbers have not lied over the years, and yet we haven't really acted in an intentional way specific to these communities that have been disproportionately affected by HIV. We need to become comfortable with the uncomfortable and start addressing the structural barriers like racism and discrimination that continually perpetuate these outcomes. Every organization here needs to focus on the communities that we have been talking about for years. Our communities aren't experiencing the same prevention gains as other population groups, but we know that the kinds of interventions that work, such as targeted, culturally specific, and intersectional, are the ones that will have the most impact. If we don't work in this way, we'll continue to see an apartheid of outcomes. We need to be intentional about the way that we finance our work. We need to ring-fence our funding. We need to focus on the disproportionately impacted communities, and we need to implement redistributive justice in the way that we work. The second aspect that I want us to focus on is normalizing HIV testing and prevention across historically overlooked communities. Now, this is something that we're already doing, but we need to focus on it more in those disproportionately impacted communities, specifically Black, African, and Caribbean, migrant and asylum seekers, people who inject drugs, folks who work with substance misuse, mental health, and the like. We've seen the shift in public attitudes over the decades that have come from successful public health campaigns, and our work should continue to push this forward in communities that aren't hard to reach but have been historically overlooked. We need to be asking the communities most at risk, what are their challenges and what do they think the solution is? Co-producing interventions that address these disproportionate outcomes are what we need to ensure that people are engaged and stay engaged. The third aspect I want us to think about is scaling up these good practices. The answer to ending HIV transmissions doesn't lie within just the sector. As Black and global majority-led organizations, we're constantly working in ways that disrupt the status quo. We should continue to explore partnerships outside of the sector to scale and amplify our efforts. Our work, not just One Voice Network, but the community-led organizations that intersect with the wider social determinants and complex lived experiences of our service users and communities, such as migrants and asylum seekers, once again, folks who substance misuse, mental health, and housing. These are all of the aspects that we need to look at cross-sectorally so that we can ensure that we're working together to achieve better health outcomes. Are enough of us in the sector working in a multidisciplinary way? This is a question that we really need to start asking ourselves. We know that HIV isn't a single issue story, so it doesn't require a single issue solution. And the final thing that I want us to focus on, or the final thing that I want to stress, is that we need to develop a strategic, focused health plan that that's focused on the next 5 years on Black, African, and Caribbean communities. This isn't a taboo. This isn't something that we should shy away from. We know what the numbers have said over the years, and it's time for us to act in a way that's according to what the numbers are telling us. Our communities, as do many others, have complex and intersecting needs, and we know that the mixed methods of engagement work in Black, Brown, Latin American, and global majority communities. We know that they can cost more, but we know that the benefits are there. So we need to increase investment into those communities who need it the most. We need to embrace the tenets of the Black Lives Matter movement. We need to work in a way that's anti-racist. We need to work in a way that uplifts the communities that are underserved and have been historically overlooked. If we all signed up to center the communities who carry the highest burden of the worst health outcomes, I do believe that we can make 2030 a reality.
Thank you. That's going to be tricky to follow. Sorry, Ray.
I'm just going to pause because that was amazing.
It was fantastic.
Thank you, Christina. That was amazing. It is a hard act to follow. But I think what I have to say does echo a lot of your points, and it's actually, although intimidating to follow on from, it's actually, I think it does follow quite nicely. I want to talk about opt-out testing, and I want to talk about that in the broadest sense. If we think about 2030 goals, in my mind, the two things that we really have to tackle is we must scale up and expand HIV testing. And as you said, Christina, we must move outside our sector. We must move outside traditional testing practices, places of testing. We have to do that. But secondly, and I think almost as important as that, is not just about testing, it is about addressing stigma, racism and homophobia that makes many of our healthcare institutions unsafe for people living with HIV, whether they're diagnosed or not. And that is reflected in our ongoing high levels of late diagnosis. It's still 40%. It's not acceptable. And we are still seeing people presenting at extremely late stages of infection. So to be very simple, our testing paradigm needs to change. We have achieved so much to get us here, and we should be extremely proud of where we are in the UK in terms of our HIV testing outcomes. But what has got us here will not get us to 2030. We have to change the paradigm, and we have to move outside of the HIV and the sexual health sector. We have to move into frontline healthcare settings. Part of the reason I made a move from sexual health, HIV into GP is exactly for that reason. We have to sit in uncomfortable rooms talking to busy generalists and make the case for why literacy in HIV and sexual health is so important. Now, testing is a very important part of prevention, which I'm going to talk a bit more about, but there's other aspects. But we have to be in that space, and we have to change the paradigm of testing. So opt-out testing, as we've seen, has been a phenomenal success, and it's been such a privilege to be part of this. We now have 34 sites in the first wave who are live with HIV testing. We've got another 47 who are being funded, and this will triple our capacity for opt-out testing. In only 2.5 years, we've delivered over 2.2 million HIV tests. We found 870 new diagnoses, and there's way over 85% rapid linkage to care for people who are newly diagnosed. We're also finding people who've been disengaged from care, lost to care, despite having a previous diagnosis. It is clearly effective. We really need to think about what can we take from this to move forward. It is amazing that we've got further funding from the 47 sites. But when we think about it, what we've really shown is that with a powerful community voice, with very strong partnerships, first with the community, but also with UKHSA, with our hepatitis colleagues who've allowed us to incorporate hepatitis B and C testing, we've achieved something that is really beautifully simple. There's a lot of work behind it, but we now have a model that works in these very high prevalence settings. We must push to continue this, and we've got an amazing opportunity with a new HIV action plan coming up. Clearly, this must continue in the highest prevalence areas, but we must also take that model of partnership and collaboration and centering the community voice and think, how can we expand to other frontline settings, like general practice, like contraception clinics, to address groups that are not being served well by current testing strategies, as you said, women, Black African communities. We must move out of our comfort zone into those areas. So I think we can do that. We've shown that it works. There isn't a one-size-fits-all, but I think we can take those lessons of why this has been successful and move it out further. Thank you.
That's great. So Sinead, from a pharmaceutical industry point of view, how do you think you can support us, and what do you think is needed from your perspective?
Yeah. So just for anyone who doesn't know, so Vive Healthcare is a company that is 100% focused on HIV. So that is our only priority, and so we don't take that lightly. So obviously our focus is around continuing to innovate in terms of new treatments for people who could benefit from PrEP or people who have HIV. And I genuinely am really privileged to be sitting here because we really feel that we can play a part in helping to support the 2030 goals. Because we know that with new treatments and new options for prevention, obviously the more choice people have, hopefully the more people we can reach. But there's probably a few things that I would say, and one of the main things I would say is around, I suppose, equitable access to not just treatments, because I'm a pharmaceutical representative, but to prevention services generally. So a lot of people have already spoken about this today, but actually we need more touch points where people can access prevention services, because we know that there are a myriad of reasons why they may not feel comfortable going into a sexual health service, for example. And I know as a company and in partnership with Gilead, this is why we decided to co-fund, along with EJAF, who co-funded and are leading a project really looking about access to PrEP to underserved communities, and really trying to, I suppose, have a bit of a blueprint to help commissioners have the evidence to scale up. But once you get people into those services, actually then it's the conversation about the choices that are available to them, not just the choices that they may know about, not just the choices that people may assume are going to be the right choices for them. I don't think we can assume every person is the same, one size fits all. Contraception is a great example of that. You know, there are so many different options because actually one size doesn't fit all. But we're really relying on people having those conversations, really telling people what their options are so that they can make an informed decision that is right for them. And then I suppose last is around, HIV education. So what can we do as an industry to support the education around HIV prevention so that people can empower themselves to make the right decisions? And one of the things, I suppose, thinking about what we're doing as ViV, we're looking at the moment around how we can learn from our US colleagues. So today in one of the sessions, there was actually a conversation about risk and how we need to reframe the word risk. And our US colleagues had a campaign called Risk to Reasons. And this was an educational campaign. It was focused on black women, and it was around really trying to empower those women to make the choices that were right for them. And it was around reframing the risk of engaging in what could be perceived as risky behaviour, but actually then kind of making an informed decision and empowering yourself to make the right decision about what's needed from a HIV prevention perspective. So we're looking at whether or not we can take the learnings from the US right now to support everyone in terms of HIV prevention education. But we're also looking to see if we can not just provide those materials to people who could benefit, but also maybe healthcare professionals who are in those different settings that you mentioned, you know, so that then actually when there's an opportune moment, they might have a HIV prevention discussion rather than in the sexual health service.
Thank you. Okay, Claudia, what do you think to get to 2030?
Elimination of HIV transmission can really only be achieved by strong collaboration, underpinned by appropriate resource. And quite simply, we're not only better together, we will only achieve our goal together. Success will rely on 4 key areas: intelligence, interventions, individuals, and impact. For intelligence, we do need ongoing detailed understanding of the pandemic, particularly as the numbers of new acquisitions fall. And this will allow us targeting of resource where it's most needed. Crucially, we need the expertise of people with lived experience and NGOs to help us understand the stories behind the numbers. We need excellent research to guide us with evidence rather than opinion, because there is no longer any place for rhetoric. We don't have the time and we don't have the money. When we try new things, which we should, we must evaluate them, because investment in evaluations are saving down the line. Interventions. We need to harness our skills and work together across community, clinicians, public health, commissioners, academics, to develop evidence-based, and yes, you've heard it so many times, co-created interventions. And we must tailor our tools for different groups, particularly for those who've yet to see the benefits of game changers such as PrEP. And we need to know that this may well mean a different mix of interventions or weighting of them for different people at different times in different places. We need to create new interventions, but not forget the old ones. Partner notification still exists. Are we doing it well enough? Let's challenge ourselves to do it better. Individuals. As individual healthcare providers, we must offer and encourage testing for HIV and discuss prevention in culturally sensitive ways, providing the highest quality care to the person in front of us without forgetting that we are missing out on opportunities for all those people who have yet to engage. Some people will largely be able to self-manage, but others will need a lot of specialist and culturally sensitive support to get the best deal for them for HIV prevention. We need time and we need skilled staff, and this needs resourcing. Finally, impact. We must evaluate every intervention, every new service model, measuring the things that matter to service users. We must acknowledge we won't always get it right first time, And we should learn from failures as well as successes and go on to do it better. We need to accept that it will cost more to keep some people free of HIV than others. But as long as we target our resources appropriately, such as by providing more expensive interventions to those who have missed out or those who really need them, we can truly make HIV prevention more equitable. Together we have the tools, together we have the commitment, we already have the relationships, and we have the tenacity. But we need cohesion and we need a plan. BASH calls for a national sexual health strategy underpinned by appropriate resource to make sure that nobody is left behind.
Thank you. I think everyone agrees. So let's move on to James. So from a Sexual Health Commissioner's point of view.
Thank you. Thanks very much. Follow that. I mean, forgive me, I might dip in and out of quite a few things. There's a lot to cover, but I would like to go down the same sort of route that I think that this has been inspiring today. Truly inspiring to see so many people talking about equity and making sure that everyone gets the same access, which is absolutely vital. So I would equally go down the collaboration route, the partnership route. Feels to me like that's got to continue. I see that in Liverpool a lot at the moment. We see it with other areas of the country, Manchester and other places in London. Lots of partners around the table talking about how we make this, the 2030 target a reality. And in terms of, I think that's got to continue to happen. There are many partners involved in this: commissioners, clinicians, providers, obviously people with lived experience. There's a lot going on, and we need to make sure we invest in that properly and make it work properly. That is where I think the USP for the English Commissioners Group can be here. We are a network of commissioners up and down the country. I think it's our message, certainly my role, my ambition, to make sure that everyone comes at this from the same point of view and that all commissioners are supporting services and are funding them properly if we can. But there's a challenge there, obviously. But I think building on what Kevin and Minister Gwynne said this morning, I just think it's about being brave. I think you've just said it, Claudia. There's a lot that we can do, I think, around PrEP, equity. Let's embrace some of these new technologies. There are injectables coming. They may be challenging to bring into the market, to move out of the typical clinic-based services, but I think we need to provide as much access to that as possible. It's an exciting time. There are various trials that we've heard about today. The Brighton Emerge online app, Bristol, the feasibility around pharmacy. There's all these opportunities that I think are going to get us there ultimately. But just to say something maybe slightly different, I'm really proud of the commissioning that we've got going on in Liverpool and in other areas in Manchester. I just think that the bit we perhaps haven't covered so far is that peer support element. As we move more towards identifying people living with HIV and there are no new cases, that sort of engagement and re-engagement in care is a big thing. We commission a peer support service and an intensive support service, and I think all of that complexity needs to come into it to make sure that we've covered everybody and that we reach the goal ultimately, and commission some different innovative things as well around sort of secondary prevention, formula milk, HIV formula milk, and so on. I think it's all there's a lot that we can still do, and I think in terms of we've done English commissioners have just recently done a piece of work understanding people in terms of PrEP access up and down the country, barriers and facilitators, awareness raising. Many people telling us they didn't even know it was available. An empowerment piece around PrEP for women, to bring women in on PrEP as well. I think there's so much that we could be doing to reach the target, and I think from a mission point of view, from an English Commissioner's perspective, we're going to run more masterclasses and try and make sure that commissioners are up on this and understand where we need to be, what we need to do, Ian. So I'll probably leave it there. But
thank you. Okay, Adam.
Yeah, thanks. So, yeah, how to follow all of that. I agree with a huge amount of what the panel's already said. I think what Christina said about how we need to work with communities and really address those intersectionalities, I think is absolutely crucial. And I think that's a real challenge for us. It has been in sort of national policy making, so really keen to see us improve that. Really agree with what Rachel said on improving the literacy of generalists on HIV. I think that's going to be really, really important. And I also think what Claudia said about good working relationships really being at the heart of how we're going to get there. All of us work in such a complex environment. It's hugely complex nationally, big organisations, sometimes with slightly confusing responsibilities. Then all the systems below that, we've got regions, we've got cities, we've got metro areas, we've got ICBs, we've got local authorities. Some of which are coterminous, some of which aren't. That is quite a soup of things to kind of wade through. So to try and bring, from a national perspective, to try and bring as much clarity of that to the next action plan, I think is going to be really important. And for me, one of the areas that the previous action plan really didn't talk to enough was that national to local to regional sort of picture, and how can, from a national perspective, can we support and encourage local areas as much as possible while also respecting that local autonomy. I also really want to highlight the importance and one of the critical success factors, I think, in England and the UK is the excellent work of UK Health Security Agency and sexual health clinics across the country on our world-leading data and epidemiology. Without UK Health Security Agency and the work they do. Yes, thank you. Round of applause for UK to say. That, as I say, that is really one of our critical success factors. So I think, supporting them is really important. And I'd also say, resources is, expectations are high of the new government. The Chancellor and the Prime Minister, I think, has been pretty clear that we are in a tricky financial situation, certainly for the next couple of years. So I think, what I can commit to from a national level is to be honest with you all on that and to have frank conversations and to sort of involve partners as much as possible if there is some difficult prioritisation ahead. I think in terms of other things, one of the ideas that we've had, which I'm sort of announcing now, is I know, get excited, is the potential for a new fifth objective in the new action plan, which could cover maybe some of the wider system issues that we weren't able to cover in the previous action plan, to look at services, to look at how we can support them more effectively, to look at education, and to hopefully look at some of those workforce issues, because I think the HIV workforce, the GUM workforce, other colleagues, CSRH, which obviously supports sexual health services, nursing, all of that is absolutely critical to achieve in 2030. So I would like us to look at that as well. So yeah, that's it from me.
Thank you very much. And Richard, I think you might have a view on this topic.
One or two. So I'm going to try and focus on some things that I think are things that we should be trying to get in the action plan that really address the health equity point that has gone through the kind of panel here like a stick of Blackpool rock. I think this is the theme of the conference and our objective today. So if you take across some of the themes we want to work across on prevention, I think we're not going to get where we need to on PrEP unless you can at least dispense, if not prescribe, from pharmacy. If it's not really accessible in the community, or there isn't a kind of national social health clinic that can, through an online service, distribute PrEP around the country, we really aren't going to get those who are health literate out of the appointments that we need to get them out of, and the capacity to get people in front of communities where we need to. And colleagues are here from Brighton, where we've seen exactly that model through the PrEP Emerge app, releasing capacity to go into communities to do an outreach clinic for sex workers, trans communities, people of colour, migrants, like exactly what we need to be doing. We should do that nationally. Finding those who are undiagnosed, we've got to get opt-out testing now into GP surgeries in high prevalence areas. That is absolutely where we will intervene in the health pathway of those most likely to be undiagnosed and those that would never otherwise get to a GUM clinic or facility to make that happen. And I'd like to obviously see opt-out testing rolled out in all of those 47 that have got the funding. That would be nice in itself for them to spend that money that we fought so hard for them to get, and obviously for that funding to be multi-year. I think we've got a lot of work to do on helping those who are newly diagnosed or new to the UK with HIV and making sure there is really good peer support and peer-led work to make sure people can come to terms with a HIV diagnosis, and that includes counselling support and being around others living with HIV. I think for those lost to care, we've got to have a voluntary sector-led with honorary contracts in the NHS way of reaching out to those that are not going to their appointments. We literally have a list of who those people are. Like, we don't have enough doctors and nurses in this country, and if you wanted to go about doing it, it takes years and years to train them up. We have a vibrant voluntary sector that could step into much of that work and do those phone calls from tomorrow. On stigma, we've got a lot of work to do across the board, and I think we need to do part of the action plan should be looking at that going forward and really doing some concerted effort to try and make a dent on a national level on stigma, because the truth is we haven't talked out to the country as a whole country since the adverts went out in the late 80s. Workforce, I think, is really important, but there's lots of things we need to do, and Adam's talked about addressing some of them. But I went to BASH conference a couple of months ago, and I was in a session about talking to your patient about sex, and less than half of the clinicians in the room actually talked to their patients or their service users about the sex they were having. They might have checked off a who do you have sex with, but that was basically the start and the end of the conversation of the sex that they were having. And by definition, if they were at BASH conference, they are the better half of those sexual health clinicians, right? The ones I worry about, the ones who don't go to BASH conference, right? So if we can't talk about sex when you are a sexual health clinician, what chance have we got that GPs are doing it, let alone anyone in A&E? But if you look through those social determinants of health, on every single one, whoever's come up with it and done their own diagram or their own thing, who you have sex with is clearly a determinant of that bit, but it's always the bit that gets missed off. And finally, I'd say, speaking as somebody from the voluntary sector, not just on behalf of it, is we need to be there in 2030. We've seen really pivotal organisations close this year in the HIV sector, not least AIDS-MAP, and the amazing work that we know they did on treatment advocacy, and we will miss them being part of the HIV family. Others, I've been open about the challenges we've had at THT and how we've had to half the size of our organisation to be able to stay focused and be here and to try to do what we can to end new cases by 2030 and make that impact on equity. And partly because we've been so open about it, some of my colleagues, some are in the room, some are not, have been quite open with me about the challenges that they're having. And in truth, we are really struggling as a sector, and if people value us around the table, they need to fund us to be there. And often the expectation is not just that we're cheap, but often you can get what we give for free. And the truth is it all costs money. So that's mine. Thank you.
So brilliant speeches all, and I'm kind of struck by a couple of things that I think are true at the same time. And the first one is I'm just going to say it out loud, and I don't think I've got any NHS England comms colleagues to tell me I can't say stuff today, which they like to do quite a lot. But we're not going to get there if we do what we're doing today. So we have a 2030 national deadline, and we all know that in the room, and I don't want people to forget that, because we're all talking about brilliant things. There are brilliant things that everyone in this room is involved in. So there is a kind of harnessing of that collective power, and we do see it. So I don't want to be sort of relentlessly negative about this, because actually something like the opt-out testing programme that, there's a few of us who work at NHSE who are here who work on it, but actually there's probably 1,000 people working on that project. Every single site has got people working on it who are only paid as part of their regular day job to work on it. And yes, we've managed to integrate bits of peer support, and we've touched on some of the bits we've done today, but there is a magic in HIV that is not there in other places that I think if you just do HIV every day you can sort of forget, which is that you have the best story in modern medicine now. Obviously it didn't start like that. But because it didn't start like that, because it comes from that dark place, it's now a hopeful place, and it's something that we can coalesce around. And I've spent a lot of time talking to people in other countries, both developing world countries. I'm talking to Pretoria, who are thinking about doing opt-out testing for hepatitis because they don't even know how much hepatitis they've got in the country. But also, I was talking to the Robert Koch Institute, which is the German equivalent of what Public Health England used to be, what UXA is now, and they cannot believe what we're doing in opt-out testing. they were sitting there going, we need to do this in every city, but actually they need to change the law first. So my answer is, we'll change the law then. So at the same time, we are not going to get there. We're still being looked at as a genuine world leader, and that isn't true. I think it's fair to say, Adam, it's not true of every single aspect of our health system. But for HIV, we are looked at as this kind of this powerhouse, and I want us to be able to tap into that. So I'm going to do my follow-up question, which is the same question to all of you, which is, in order to tap into that, what can we do as individuals to get there? And again, I'm going to go from Christina down the panel to go, what are you as an individual? Because at the moment, reflecting on what you said, Christina, we're not avowedly anti-racist in all the work we do. I think we want to be, but there's something that kind of almost holds us back from just going, no, we are going to do this in an anti-racist way. We are going to acknowledge the fact that we are dealing with populations who the services, and talking on behalf of the NHS kind of quite often sets up services in a way that suit the NHS and don't suit the public it serves. So how do we change that? And what, as an individual, because that's the takeaway that I want everyone to get. We carry on this fight, we will get there. We carry on, we work out the things that work really well, and we will get there. But what can we do as individuals is what I'd like to get out of the rest of the session. So Christina.
So I think as individuals, I think the first thing is to just reflect on the bias that you have. All of us are born with, or we're not born with a bias, but bias is learned. And so it starts when you're very young. And I think trying to, nip it in the bud as early as possible. So whether that's having conversations with the young people in your life, if you work with young people, having that conversation at an earlier point. And then as you get older, talking with your friends and your family in a way that normalizes the need to have this kind of conversation. If you were to ask me what I think is maybe like the biggest barrier, coming from Canada, where colonization is something that's talked about very openly, it's not a conversation that I think is had here. And I think when you reflect on the colonial history of your country and the way that your services are set up, then you realize that the people that are disproportionately affected are the ones that were on the butt end of the colonial history. And so the moment that you can So I think the moment that you start to recognize it and you start to act on it, you need to name it. You need to name the issue. And so starting from that point, and then working to be anti-racist in the way that you work. I think that's really how it begins. So that's my answer.
Thank you. And Rachel, what are you going to do? And are you going to continue to work with me? I hope you are. If you're not, this is a really embarrassing place to...
We're going to have this conversation.
Yeah.
I think it's a really good question. I like the way you phrased it. What are you going to do about it? Because I think we all have to ask ourselves, what are we going to do? I mean, it's easy to push back and say the government should do this, the system should do this. But actually, if I think about it myself as a clinician, there is so much that has been achieved by clinicians, by teams, by partnerships to get testing and prevention efforts up and running. Part of the reason we have this amazing opt-out testing strategy now is because of the community partnerships, and it is also because dedicated clinicians and teams on the ground banged their heads against a wall for years and years and years, and they worked out the pathways, they got funding, they scrabbled together a way of doing it, and they worked out the SOPs. And that allowed us, when we finally got the funding, thanks to the lobbying of THT and all of the community sector that made this possible, we were ready to go. And this is because people did not give up. We have had opt-out testing and guidance for nearly a decade now, but it is people who persevered and said this is clearly the right thing to do. People are at risk, people are dying unnecessarily of HIV, they're being diagnosed late, and people started taking action on the ground. And there's pioneering clinics, I could name so many, who said, no matter what, even if there isn't national funding, we are going to do this. And so I think it's beholden to us all to say it is the right thing. We can't just say, oh, it's very difficult and there's not enough money and it's all very hard. We have to say it can be done. We have to say it is the right thing. We have to reach out to our partners who are ready and willing to work with us. And we have to just take action and get on and do it. Because we have seen that if you can demonstrate good practice, you can develop a model that works, then when funding does finally become available, you can take that and run with it. And we have such an opportunity now. So we have to keep going. We have to hang on in there. We have to keep talking. We have to keep meeting. We have to keep, we have to keep at it. And I think back to your point, Christina, it's not just about, I'm talking about testing, but it's not just about testing. Testing is a way in, particularly thinking about frontline healthcare settings and generalists. It is a way into the conversation about HIV literacy, about talking about sexual health, about sexual histories, about intimacy. We need these conversations to be happening in order to address the racism, the inequalities, the stigma that is behind all of this. So testing is one way in. And I'd just like to share an anecdote from, we have a lot of our meetings about HIV opt-out testing on a Friday. I heard this amazing story from Orla McQuillan that many of you may know in Manchester. She set up this fantastic HIV stigma module in Manchester, and it was really difficult to get uptake amongst the clinicians. She had about a few hundred people doing it. And as a result of the phenomenal success of their opt-out testing project there, they now have about 7,000 hits on their module. So this is why it's important. We have to keep talking about it. We have to keep pushing opportunities to have these conversations, getting out of our safe spaces into areas where people may not be talking about HIV, may not be talking about testing. And so this is a great opportunity. So I think as a clinician, that is what I'm going to keep doing. I'm a practicing GP. I make it my business whenever I'm doing blood tests for tiredness, for diarrhea, for feeling a bit off colour, for tingly hands. I say, oh, we're going to do a routine HIV test along with all the other ones. And I have not had one person say no. They say, oh, fabulous, that's great. Not one person. And I see, as I'm doing it, it is a great delight to me that I see my colleagues starting to do it. If you start doing good practice, you will see people doing that.
Just linking this in terms of personal power. So the first time I met Rachel was on a Teams call, and it was when opt-out testing became a thing, and I'd already determined if opt-out testing, when I got the news that the money had come through, and I didn't know that was happening, when the money came through, I was in the post-COVID world. I'd been in critical care for London in the pandemic. It was horrible, and I sort of figured that, right, there's a program here that the clinicians have all told me they want to do. I'm going to do that. I'm doing that. No one else gets so personal. I'm doing this, and then I see Rachel. The first time I've ever met her, she went, "Hi, I'm a clinician. I want to work on opt-out testing. I'm not leaving." that is personal power for both of us, right? And we are working on this program. So when I tell you have power in this room, you really do. And the more we link together, the more that stuff happens. Yeah. Sinead, what are you going to do?
Hard act to follow. Okay, so I'll keep it brief. So what can I do? I mean, we have a responsibility when we have invested in new medicines to do our best to get them reimbursed and out to the people who need them. That's one of the key things. The second thing, it sounds simple, but it's around then educating healthcare professionals about those treatments, because they're the individuals that have those discussions with people who may benefit. And then the third is around continuing to be a bit pushy. So I see sometimes that there are disparities in terms of access. And obviously I'm talking about treatments here, but actually how do I raise that amongst my team, amongst my network, because actually there are differences around the country. And I suppose last but not least, we always try to be a partner where we can, and you've got my commitment that where we can, we will continue to partner with everyone as much as we can in various projects.
Thank you. Claudia.
I'm going to do three things. I'm going to continue pioneering for excellent research because we need the evidence. I'm going to enhance the number and different ways that I work with different organisations. And across the border in Scotland, we have a very strong track record. And that involves me co-leading Scotland's PrEP strategy with the Chief Exec of Waverley Care. And I'm really proud of that. And I'm going to continue my learning with the person in front of me. Continue to learn about their cultures. Continue to tailor. Sometimes that won't involve me asking them about how comfortable their sex life is if it's not right. Sometimes that will involve me asking them really personal questions, and I hope that will be informed by working with many of you with different backgrounds and different experiences. And fourthly, I hope I will continue to be humble, because this is a big journey for all of us. And for many of us who are going as grey as me, as you rightly said, this has been going on for years. And I want to continue feeling privileged that my career in medicine has let me work with phenomenal people and to get to a point where we could reach transmission elimination.
Brilliant. Thank you. James, how about you?
Yeah, on a personal level, I'll stick to 2 or 3 similar messages. I think I'd like to think that I could continue to inspire others across, certainly across the Liverpool City region, Cheshire and Mersey, and nationally, and work with other commissioners to try and improve services as much as possible. There's something about continuing to challenge stigma on an ongoing basis. Whenever we hear it, we should challenge it. So I'll continue to do that and to obviously champion good access to testing and PrEP and all the things we talked about earlier and that have gone on today. I think the other one is very passionate as a public health lead about working with communities on an ongoing basis, listening, understanding, carrying out insight work, reducing barriers. And I think that's the bit I'd like to make sure that I continue to do on a personal level, to go and do some, we've done some great focus group work, we've listened to people, we've carried out insight work based on COM-B. All of that sort of stuff I'd like to continue doing and feed that into plans that make a difference to people so that we're doing things that actually follow what is wanted and not what we think is wanted. So from a personal level, that's certainly what I'll do. And as I said earlier, probably the additional is to continue with some of the national support for commissioners who might need it.
Yeah, brilliant. Thank you. Adam.
Yeah, I think the main thing I'm going to do is actually to listen to everyone. And if anyone has an idea about the new HIV action plan, you are very welcome to email adam.winter@dhsc.gov.uk. That's adam.winter@dhsc.gov.uk. There's a perception we're in the department in our ivory tower, but we do have email addresses. We even have phone numbers. So and I very rarely get a phone call actually. So do get in touch. I mean, Claudia mentioned humility, and I think that's also really important. I think I've worked in now HIV. I've been fortunate to work in HIV now for a number of years, and I think there is for me a really interesting balance on we need to continue with what is working, but also to get to that final couple of thousand people undiagnosed, we are going to have to do new things. So we're going to need to be open to new ideas and to doing things differently. So I think humility is really important. And also another thing for me that's really important is candour. We don't have unlimited resources. There may be some things and some ideas that people want to do that are too difficult to implement, that we don't have resources for right now. So from a national perspective, I want to promise you honesty about that and to kind of engage you in those conversations on prioritisation. Thanks.
And Richard.
I'm going to do a couple of things, and people have mentioned some that I think is important for all of us to take on board. But I suppose, firstly for me, I'm going to ask for more money, and whether it's to fundraise for THT and make sure that we're getting that from private donors and individuals out there that say they support our cause and make sure they do, because the freedom to say sometimes the candor back the other way, we can only get because we're funded by the community sector. But equally, for this programme that we're in now, when Labour left office, there was, in 2021 prices, £4 million being spent on what has become HIV Prevention England. It's now 1 million. So we have a quarter of the money while trying to find, yes, less people, but by definition, the people we keep saying, we need to spend more, do more to make sure we're finding and diagnosing. And I would like to say to our friends in pharma, who are lovely and generous, can we think about, one, looking at the best practice in America? It's one of the things they do get right, is the funding that goes from pharma to the community. But can we move from grants to a strategy for funding the sector? Us spending so much time filling in forms to jump over the hopes on your terms. You've got great budgets, on everything else you strategise. On the rest, you let us come with a begging bowl saying, please, can we do this little bit with you? And if we can change that relationship, it might mean you work with less of us, but in really transformational ways for maybe, one going for 3 years and something. So I think we should do that. For me personally, I think I have some opportunities because of either where I work and what I've done before to get in the conversation, particularly with the new government, and I want to be committed to not only bringing people living with HIV into those conversations directly, but people who have very different lived experiences to me into those. I think that's a really important personal commitment to make. And then thirdly, to keep taking THT to that place on health equity constantly. It's easy when you want to be the national leading organisation to always go for scale and want to get big numbers, but sometimes there is an interplay between scale and equity, and we try and get both right all the time, but I think the most important thing is starting with those who are having the worst outcomes and making sure we deliver from them and work out from that point, rather than go to those who might be first at our door and hope we get to the right people at the end of the day.
And just to round up, I'm going to say what I think I'm going to do. So I'm going to continue to work on the opt-out programme quite clearly. I'm not leaving either, and I'm not leaving the sector because I can't. But not because I'm physically unable to, but because I don't want to emotionally. Very clearly, it's because it took me 12, 13 years to get involved in HIV at all, and now I'm involved in it. I'm involved till it's finished, and that comes from, and going back to what Christina said, I'm able to do that because I have relative status that comes from my class and my positional power and my race and my gender that isn't available to everyone. But this is a plea to everyone in the room. If you have that bit of imposter syndrome, which for some reason I don't seem to have, I believe it is most people do have it. I am here to tell you that this is your space. So this is your space. So every time you have that thing on your shoulder going, oh no, it's not for me to email Adam. No, it is. Not just that. But this, and I had a conversation with Liz about this a while ago. This space about, oh, I'm not quite sure what to do next. I'm not sure how I can make the difference. Or this thing is really bugging me. Or this person isn't paying attention. Tell them. Tell me. If you can't tell them, come to me. My email address is i.jackson@nhs.net. It's quite an easy one. And we won't solve every problem. I can't help with every single issue. But there is a movement in this space and in this room and on this panel and more importantly on the floor of people who've got brilliant ideas that will make things better for massive amounts of people. And it is the only space I've ever really been in, this now the hepatitis world, where that actually happens. And it happens because of you, not because of us. So I want you to seize those moments every time they become available to you to go, actually, no, I'm not going to wait for someone else to make a fuss about this. I am going to email the person. You don't have to get your boss's permission to email us. You just talk to us. And as I say, we can't fix everything. We never will be able to on our own. But actually, every single bit of those conversations feeds into the narrative, feeds into the conversation, feeds into the plan, helps us do the research, helps us generate how we behave as commissioners or as pharmaceutical industry colleagues to go, well, actually, the big things we need to be able to achieve are X, Y, Z. And if you don't have that conversation with us, it won't play in. So I want you to realise your own power and to keep going with what you're doing, but come out of this with a sense that you are powerful and you are, more than that, you are mighty. So I want to thank the panel, thank everyone for being here today, and mostly thank you all.
So before we head off from the day, I want to thank Ian and all the panel for that amazing last session, for all the speakers from today, for such amazing contributions. And of course, it wasn't just the speech itself, but the work you've done prepping the presentation and the speech itself. And then, of course, all the research you've done before that to do the presentation and the speeches. It's been amazing the endeavour we have seen in this room and how this sector is so inquisitive about what works, so determined to focus on health equity, and so striving to meet this amazing goal of being the first virus where we could stop the onward transmission without a vaccine, without a cure, to be the first country to do it, and to do all that by 2030. We've seen various things said throughout the day, and I think they fall into some important themes to feed back on. Firstly, this bit about equity has been there on every slide going forward. We don't want to end the epidemic for one group or one community, one city, one place. We do it together, and I think it's really important to make that happen, and that when we're doing that work, we're purposefully in that space. Secondly, so much of our health service is about the 20% that is healthcare. What about the 80% that is those social determinants for health? And I think they come up all the time in all of those sessions, that really the issue isn't about the medicine. And we thank Vive and Gilead and MSD for giving us the best medicine in the world. But HIV isn't about the medicine anymore. It's about those social determinants of health around it. And that's where we need to be so active in this space. It's where no organisation could have a monopoly, and it's where we can only make impact if we work together and we see what each of us can bring in different ways. Thirdly, that we today have made a step forward, whether it was the Minister announcing that we will have an action plan, that we will revise that data, dashboard data for the country on 90-90-90, so that those 14,000 lost to care aren't suddenly reduced to 2% of those diagnosed, because those two numbers do not work. And by some of the conversations I have seen happening, and I've seen today me huddling with staff, right, this is an action we need to take forward, and I've seen it with others and other organisations here today. So this conference itself hasn't just been a time to learn and reflect. I keep seeing these huddles of action. This is a to-do list that many of us have come up with. I'm really lucky to work for an organisation that is so amazing in lots of ways and gets to work with such amazing partners. And I'm very lucky to have that strength in the voluntary sector, in the HIV community, that have been incredibly supportive of me and the organisation for its time. I have some wonderful staff, many of which are represented here in wonderful T-shirts and other things. Taku has led today and the team on HIV Prevention England so brilliantly, and I know all of you enjoy working with him, and whether it's Brogan, Thomas, Barry, Joe, or others in the team that support him, as well as the wider THG family. Together we do that really well, and he is a phenomenal thought leader in this space and a man who makes things happen, which is the thing I most respect in the world, and we couldn't do any of that stuff without our activation partners. So thank you very much for all of you being part of making HIV Prevention England a coalition that is so impactful. When I was in one of the sessions, I looked out the window very briefly, and it was St Thomas's Hospital. And it made me just stop and think for a moment that that is where Terry Higgins died. And that is in many ways where this journey started. And you think the physical distance of how far we've come, and then you think, as Ian has said, really the journey that we have gone on, and the fact that we all are a footnote in various ways in the most remarkable medical journey that has ever happened, and the most remarkable turnaround on something that started in such a desperate plight to one where today we have that sense of hope that we could be the first country in the world to end this epidemic. And I suppose the only thing left to say is we can only do it together. I hope you had a really brilliant day. Thank you very, very much. Thank you for being here, and good luck. Safe journey home. Have a great weekend.